and give us your remark on this occasion, please. Please welcome them. I'll also request Babu sir, please on stage. Please come to stage. As you are aware, the World Breastfeeding Week is celebrated first week of August since 1992. I request our director ma'am to give a few remarks and initiate the session. Thank you.
Very warm welcome to all of you and happy Breastfeeding Week. My voice is repeat. My voice, although apparently it looks like we have very thin audience. We have 40 participants online. Therefore, 50 participants online as per Dr. Srishwan. Once again, I extend my warm welcome to all the participants, experts from Nilofar Hospital. We also have experts from Gandhi, I think. And then we have from JIPMER, the neonatologist and pediatrician from Chandragiri. Very warm welcome and pleased to have you all with us on this important occasion. All of us know very well there's no need to repeat how important is breastfeeding in maternal child health practices, particularly with respect to child health and in the prevention of child mortality. There are many policies in place and India is very actively participating. And also the positive aspect is in the recent past, institutional deliveries have increased considerably. Actually, this should be taken as a premise to improve breastfeeding. If at all, we actively see that all the private hospitals and also government hospitals follow the policies that are already existing. There is no need to create new policies, but even if we implement existing policies, it will go a very long way in improving breastfeeding practices. Actually, from the NFHS 5 data, it is improving very, very slowly. NFHS 5 data, if you see superficially, apparently it appears 60% of the children are exclusively breastfed for 6 months. But is it true? No. I mean, cross-sectional, the data is cross-sectional. So up till 6 months, they have seen that 60% of children are breastfed. But then if you go back and see individually, it is hardly 30 or even less than 30% who actually follow 6 months exclusive breastfeeding. The policies are existing, having a written infant feeding policy in every hospital, which has neonatology, which has obstetric and gynae department, have written infant feeding policy in place and ensure that all the staff is sufficiently trained, has the required skills, knowledge regarding breastfeeding. Only if they are skilled, they have the competence, they have the knowledge, only then they can instill and give appropriate counseling to the mothers and the people who are around a newborn baby. Then also data monitoring, regular data monitoring should be in place. These are all there on paper, but I am not sure if hospitals are following. Even the government hospitals, I'm not sure if they are following, but actually it is mandatory that all government and private hospitals follow this when they have neonatology unit or when they have the gynae obstetric unit in them. So once again, I extend a very warm welcome. I'm sure all the participants and deliberations will be around this. Yes, community participation in breastfeeding is also very important, but when the mother delivers in the institution, if she gets sufficient knowledge there, definitely she will ensure that her environment is conducive to continue breastfeeding for 6 months. So not only the community participation is important, but clinicians, obstetricians, the health workers around the labor rooms and the neonatology units should also be adequately equipped to render this knowledge to people. So extending my warm welcome, I take leave and my best wishes to all the panelists and the speakers. Thank you.
Thank you, ma'am. I now request a representative for Save the Children, Dr. Prashanti, to give her remarks.
Very warm welcome to all of you. Very good morning. I'm not Dr. Prashanthi. I'm just simple Prashanthi, more from the community perspective. Thank you so much for all the participants and like offline and online for being here for this morning consultation, which is very, very important, not just for our country, but also for the globe. It is, it's very clearly, explicitly mentioned that breastfeeding is more important to start immediately after the birth. And I think a great deliberations have started with the, welcoming note from the director, ICMR Nayan. We are, very hopeful and very, waiting for the today's speak, the sessions that will be around of this importance of breastfeeding that should be started as soon as possible. Thank you once again for all the team, the speakers, the panelists that are here today to discuss on this important topic. And we are hoping that there will be good discussions, and then there is a message to take forward for the, practitioners as well as for the mothers and the parents from the community to learn from today's session. Thank you so much.
Save the Children has been associated with NIN for many years, and we appreciate your support in this for this breastfeeding celebration. Thank you.
Who organizes actually Save the
Just to take this opportunity to also inform that Save the Children is now taken as Bal Raksha Bharat as an Indian entity. So it's an international name as Save the Children. We have registered as Bal Raksha Bharat in India, so we want to go with the same name hereafter.
I now request Prashanthi ma'am to felicitate our director with a moment.
Which
Breastfeeding.
breastfeeding. Yeah.
It's okay. Take time. You're going to open the box also?
Yeah.
Yes, take your patience.
Sometimes birthday gifts are like this, so you open and then finally you find what you want.
I request Director ma'am to felicitate Prashanthi ma'am.
Same time.
Yes. I request Director ma'am to felicitate Babu sir. It's my pleasure to introduce our first speaker, Dr. B. Adishivam. I should tell you, we are friends from school. So, Dr. Adishivam is now the professor in neonatology at JIPMER, and he also is a deputy medical superintendent of Women and Children Hospital, JIPMER. He has done his MBBS and DCH from JIPMER, and followed by DNB from Child Trust Hospital, Chennai. And he has also completed his PhD in breast milk banking at JIPMER, and he has established the breast milk bank at JIPMER under the guidance of Professor Vishnu Bhatt. He is one of those rare clinicians with an inclination towards public health. I remember accompanying Adi for a field survey during our MBBS days, and he also was awarded the endowment prize for community medicine for MBBS. So such is his interest. And he has that balance. I always say to him, he has that balance in everything, which I try to see that I make. He was always our role model, and he has several projects to his credit. Some of them high-profile projects, and for example, the principal investigator of the probiotic supplementation and prevention of neonatal sepsis project, which is an international project, and he was also the principal investigator of Global Neonatal Observational Study, and he has over 133 index publications. I'm really proud to introduce him to this audience, and I look forward to hear from him of all his experiences, and I'm sure we will benefit from his talk. Thank you.
Yeah. These are question and answers.
Good morning. Thank you, Dr. Venkatesh, for your kind words. At the outset, I would like to thank National Institute of Nutrition, the organizing team, for giving me this wonderful opportunity. So I will take you through the art and science of breastfeeding, touching upon the common issues and a few solutions which we can offer. So you would be aware that the theme for this World Breastfeeding Week 2023 is enabling breastfeeding, making a difference for the working parents. Every year we celebrate World Breastfeeding Week. Actually, we are the only mammals who have to be reminded that we need to breastfeed, which is a natural phenomenon. So the real success is when we stop celebrating Breastfeeding Week and we do it on our own. Yeah, fine. So I have a disclaimer. I can only talk the walk, but there are a lot of mothers here who actually have walked the talk. So before I begin my talk, we'll have a short video. This is a UNICEF video. Speaks for itself. You saw that? So every animal which took the same species breast milk was calling the mother fondly as mother, right? Whereas the human being, more so in the name of civilization, we are slowly moving away. And the children who take formula, imagine the formula tins as their mother. This is a sad state of affairs. So as I said earlier, I'll just go through the current trends and practices, the science behind the common aspects of breastfeeding. I'll touch upon human milk banking and the challenges and solutions. So can anybody in the audience virtually or online or offline identify this person?
Cecily Williams.
Fantastic. So she is Cecily Williams. She was the physician who coined the term kwashiorkor. You can see the child there with the typical features of kwashiorkor. Dr. Cecily Williams have done wonderful work in the field of infant nutrition, especially in the field of breast milk. She has written the book Retired Except on Demand, and famous for her paper on milk and murder, where she has brought out the strategies of the formula companies way back in 1939. It's almost 20 years. She was in fact in one of the post-war scenarios. She was in a refugee camp. She was taking care of the children who were born in the refugee camps, and she puts in her notes, this is 80 years back. 20 babies born, 20 babies breastfed, 20 babies survived. You can't do better than that. These are fantastic words, holds good even for today. And when breast milk can save so many babies in a refugee situation, in unhygienic conditions, 80 years back, we can still do it on our own. So for a successful breastfeeding, all we need is a willing and motivated mothers. It's not that simple. Though it's a physiological process, all the mothers need to be informed regarding the advantages of breastfeeding and the techniques of proper breastfeeding, the correct attachment antenatally, so that the mother is prepared emotionally, physically, and mentally for starting off the breastfeeding as soon as she delivers a child. So that should be the idea. And of course, we need an active and sucking newborn. With advancement in perinatal care, even preterm babies, we are able to make them survive. But it's not the question of just survival, it's intact survival. How are these preterm babies, the vulnerable cohort, going to do after a period of 1 year, 1.5 years? How is the neurodevelopment going to be? Talking of neurodevelopment, breast milk is a key factor both for term as well as for preterm babies. And of course, not last but not the least, a motivator who can bring both the mother and newborn together, right? It necessarily need not be a pediatrician or a physician or a nurse. It's a society which should bring the mother and baby together. In fact, the breastfeeding movement should be a social movement. So as Madam pointed out, this is the NFHS 4 and 5 data comparison. If you can see carefully, the breastfed infants within 1 hour of birth is almost similar between NFHS 4 and 5, whereas exclusive breastfeeding, there's a slight increase. As Madam said, even if it tease out the data, it may not be the truth. Of course, the mortality indicators have come down. I may not say that breastfeeding alone is important for bringing down the mortality, but exclusive breastfeeding is a key parameter in bringing down neonatal mortality. According to the recent 2023 Lancet series on breastfeeding, only 1 in 2 newborns are put to the breast within the first hour of life. This is a very sad situation. Imagine when a baby comes out, especially delivered vaginally or even by LSCS, they are more vigorous. It is easy to latch the baby immediately in the golden moment. So if we keep on delaying things, both the mother will be tired as well as the baby will be tired. Then it'll be very difficult to put them on, and a lot of complications for both the mother and the baby. So we should always, whatever may be the route of delivery, whether SVD or LSCS, one should ensure that the mother and baby are together and should not be separated unnecessarily and breastfed at the earliest. So in JIPMER, in JIPMER, even despite being a tertiary care hospital, even our first hour delivery initiation of breastfeeding, early initiation of breastfeeding, that is initiation within the first hour of delivery, was quite low. So we brought in this bonding angel program. It's almost in lines with the Lakshya program. So where our nursing students were simply in the labor room watching the delivery, were labeled as bonding angel. Their only job was to bring the mother and baby together, and they were given a certificate of bonding angel. They got their certificates and babies got the milk. And nurses who were busy with the delivery were also happy with their work. So this program has been running successfully, and we are able to carry it through. Sensor is here. Okay. Okay. So touching upon the basics of breastfeeding. This side. No, I'm going to the previous slide. Previously.
Next, sir.
Next slide.
Forward, na?
Yeah,
Yeah,
next slide.
forward. Yeah, next. Next. Which slide? Yes.
Stop. So a word on cholesterol. Something wrong with the cursor, I think. Okay, doesn't matter. So talking of colostrum is an important, the first secreted milk. All of us, it will be very primitive if I say in this institute regarding colostrum. It has got all the benefits, and the practices of leaving of colostrum or letting of colostrum or devoiding the baby of colostrum should be avoided, right? Because it contains vitamin A, all immunoglobulins, and should be fed to the baby. And it's also rich in calories, right? The next is regarding the fore milk and hind milk. The milk which comes in the initial part of the feeding is the fore milk, rich in carbohydrates and water. It may quench the thirst of the baby, but may not be enough for the satiety of the baby. That's why we insist on emptying one breast and then moving to the other one, so that the hind milk also is given to the baby and the baby gains weight, right? So that's very important. So it's not just enough that you give only fore milk. You should ensure that the mother empties one breast before moving to the other breast, right? Then a lot of fortification strategies have come, especially for preterm babies, either targeted fortification or standard fortification. So all these are lacto-engineering so that the extra uterine growth restriction is decreased. I'm not sure how this cursor is going.
Is that the next slide you want to see, sir?
Yeah. Actually, you can go back. Please go back. Please go back. Please go back. The thing is, I will say verbal command, you can move it for me. That'll be fine. Yeah, please stop here. As you can see, the breast milk contains 88% of water. So usually mothers will ask us with the suspicion whether we can give water for the baby, because baby is crying incessantly. Maybe he doesn't have enough water or getting dehydrated in summer. We usually tell the parent, even if you are in Sahara Desert and there is no water, you need not give any extra water to the baby, even during summer, because breast milk contains 88% water, and by giving exclusive breastfeeding, it's something good you're doing for the baby, and it's important for the IQ of the baby. So there is no need to give anything else other than breast milk for the first 6 months. Next, please. So if you compare the human milk versus cow's milk, there are a lot of macronutrients which maybe appear more in the cow's milk, but what is getting digested and absorbed by the baby is more important. Say, for example, though the calcium content in cow's milk is more, it is those babies who are fed on cow's milk land up with hypocalcemic seizures, because the calcium phosphate ratio is different in cow's milk compared to the human milk. So this is just an example that there may be plenty of macronutrients may appear more in cow's milk, but it may not be really absorbed or beneficial for the baby. Similarly, there are whey protein, arachidonic acid, a lot of important immunoglobulins and important micro and macronutrients in breast milk, which only the breast milk can provide and no formula under the sun can provide. Next. So why to breastfeed? This is a simple logic that, as I said, Cecily Williams have pointed out, it's for survival of the baby, the weight gain of the baby, and of course, immunity. See, so we tell our parents most of the time, breast milk is just not food for the baby. You give breast milk to the baby, exclusive breastfeeding, that particular baby will never come to the hospital apart from vaccination, because the immunity against the common infections, say diarrhea, pneumonia, ear infections, are fantastic with the breastfeeding, and these babies will never get the common infections. Whatever infections the mother has already acquired, passively the antibodies also will be transferred to the baby, and the immunity of the baby is ensured. And more importantly, these are the days of NEAT and NEXT. So the long-term neurodevelopment outcome is very important, whether it's a term baby or a preterm baby. So those babies who are exclusively breastfed, their IQ range is definitely far ahead than the formula-fed babies. Next. So not only for the baby, for also the mother, it's important, because in the post-delivery, the oxytocin is released, which causes the uterine shrinkage. There is a decreased postpartum blood loss for the mother, and it also helps her to lose weight, and there is fantastic emotional bonding, apart from the usual prevention of cancer of breast as well as ovarian cancer for the mother. So breastfeeding exclusively is beneficial for both the mother as well as the baby. Next. So this is a small point. I believe there are a lot of audience in online. And this simple thing should be known to the common man, even to the layman. This is called about correct attachment. Primary mothers, that is those mothers who are delivering for the first time, should be told about the correct attachment. It has got only 4 points: mouth wide open, chin touching the baby's chin touching the breast, right? Baby's chin touching the breast. Lower lip is everted and areola should not be seen below and can be seen above. As simply, it simply says mouthful of breast. So if you see the other side where I put an into mark, it is baby sucking only on the nipple. This is wrong attachment. So correct attachment is mouthful of breast with all the 4 points complete, right? So if you can ensure correct attachment, exclusive breastfeeding will go on smoothly. If it doesn't happen, because of the incorrect attachment, mother can develop sore nipples, mastitis. Mother will develop abscess and go to the surgeon. Baby will not get milk and go to the cow. So invariably, a small thing which we could have corrected will protect both the mother and the baby. Next. And even for the smallest babies, these are the days where we try to give mother's own milk. Even for a preterm baby may not be directly feeding on the mother's breast, say 28 weeker or 30 weeker. For those babies, we give orogastric feeding. Next. For babies who are slightly mature, we go for Palade feeding. Palade is an important utensil. Even the UK nurses try to patent it, but it's our traditional vessel where it can be easily be cleaned and it can be used safely. So I say here either Palade feeding or cup feeding will be okay for preterm babies and low birth weight babies who are unable to suck from the mother's breast directly. However, never ever advise bottle feeding for any baby. Bottle feeding is dangerous for both the baby and the mother as well as the society. Next. So a word about kangaroo mother care. You must be knowing about kangaroo mother care. It's a 2-in-1 package. The two important components are skin-to-skin contact and exclusive breastfeeding, right? All good things in this world come in small, without any advertisement packages. So kangaroo mother care is a fantastic thing especially for preterm babies and low birth weight babies. If they can practice kangaroo mother care, their weight gain is better, bonding is better. Not to forget, the microbiome by the skin-to-skin contact gets translocated to the baby. The mother's good bacteria along with the genetic material gets translocated to the baby, and there are n number of benefits for kangaroo mother care. So to summarize again, for low birth weight babies and preterm babies, always ensure kangaroo mother care till the baby reaches 2.5 kg. Next. As I said, bottle is like a time bomb. Never advise mothers to use feeding bottle, whether they clean it daily or change the nipple or sterilize it. Knowingly, they'll be giving organisms to the baby. So those babies who are bottle fed will have 6 times more chances of developing pneumonia, ear infections and diarrhea. Similarly, all these nipples, artificial nipples, if the baby is crying, we just find simple solutions by putting it into the mouth. Whatever is the disadvantage for a feeding bottle also holds good for these nipples. So we should never encourage feeding bottles or the nipples. They can also hamper with the dental development of the child. Next. So how do you know that the breastfeeding is adequate? So some of the mothers think that baby is crying, that means baby is not getting enough milk. And they think that whatever they are giving is not enough for the baby. But that's not the case. If the baby is gaining weight adequately and the baby is passing 6 to 8 times of non-concentrated urine in 24 hours, that means the baby is getting enough milk. This has to be reassured to the baby. The babies are coming out from an in utero environment to the exterior. They need to be handled. So never separate the baby and the mother. All the mother needs to do is bring the baby to the breast more often. And there is no need to put a clock between the mother and the baby, half an hour or 1 hour, 2 hours, etc. It is just a physiological phenomenon that whenever the mother feels like feeding, she should feed the baby often. Whenever the baby cries or wants to feed, the baby should be fed often. So that should be the case. Never put a clock between the mother and the baby. Next. So as I said, not enough milk is actually a myth. It's not a fact. So whenever someone says not enough milk, it's a tendency to immediately prescribe a formula. That is totally wrong. The fantastic medicine which brings out enough milk, and the solution for this problem is counseling. Second medicine is counseling. Third medicine is also counseling. So even for 100 mothers who say not enough milk, sitting with them and having a one-to-one session, you counsel them properly, most of them will be able to breastfeed. Galactagogues, of course, like metoclopramide or domperidone, more commonly which is used, can be used, but more often it is like a support to counseling and not a separate treatment for not enough milk. Next. More importantly, all these mothers should be asked to feed more in the night because the prolactin secretion, the important hormone which is needed for the secretion of milk, occurs in the night. So night feed should always be encouraged. Next. So we'll touch upon the common barriers to breastfeeding, lack of knowledge about breastfeeding. So that's one. So post tsunami, we have went to some of the rural areas in Pondicherry, in and around Pondicherry. We were surprised that even in a rural community, the use of formula post disaster scenarios. I was meaning tsunami in 2004, I think. So beyond that, people are using the formula use was more. When we probed into the question, why they, despite the economic status, they were going for formula, the answer was the media, what the neighbors were using, and of course the doctor's prescription. So sometimes the knowledge, the correct knowledge has not percolated in the community, where every individual in the society has a responsibility. And the social cultural norms, of course, we talk within the hospital after delivery, we talk to them more frequently regarding exclusive breastfeeding. But once they reach home, there are a lot of other factors, the father-in-law, mother-in-law, the society, the neighbors, a lot of other inputs come. So what we mean to say is, it's just not the mother's duty to breastfeed. Every individual in the family and the society should also encourage and should have positive impact for and ensure that she feeds the baby, right? Then, of course, there are genuine lactation problems. The important lactation problems are the breast engorgement and the breast abscess, right? So here also, the main issue is not emptying the breast. Once the breast is emptied, all these lactational issues will be settled. Some of them have retracted nipple. These can be identified antenatally itself. There are double syringe technique which can be taken care. So all these are minor problems, and all the lactation problems can be anticipated or corrected even in the antenatal period. Working mothers, that's the theme for this week. So we always say, sir, I'm a working mother, how can I feed exclusively for 6 months? Now the government laws have come, at least the government sector maternity leave for 6 months is obviously there. But only thing is, you take 6 months leave and give formula to the baby, that is not right. So, and more importantly, all the workplaces, whether government or private, should be more baby-friendly initiative should be there. So wherever possible, the mother can take the baby to the workplace also and feed in between. Or when the mother goes home, she can express the milk, keep in room temperature. In room temperature, express breast milk kept in clean stainless steel containers can be used up to 6 hours. If you keep in a fridge or a refrigerator, 24 hours also it can be used. So the grandmother or the attendant at home, after washing hands, they can use sterile or a boiled palade for feeding these babies in the absence of the mother. So where there is a will, there is always a way. So working mothers is not an obstacle for exclusive breastfeeding. In fact, they should be more encouraged to do it. That's what. Now, once you prepare the mother, even a working mother or not working mother, I cannot say mother as not working, that's a wrong statement. All mothers, if you prepare them antenatally, then nothing can come between the mother and baby, right? Of course, the policies and the promotion of infant formula, I need not say, it's very obvious. Next. According to WHO, the best for a baby is the mother's own milk, right? And for a preterm baby, the donated fresh preterm milk. The worst thing is the ordinary formula. So never ever prescribe a formula. By giving a formula prescription, you are causing harm to both the mother and the baby. Next. But there are certain situations wherein sometimes the additional effort, I'm bringing in the concept of human milk banking, right? The number of preterm births, the extreme preterm births who are being delivered are more. And India has a major chunk in sharing the neonatal mortality. And some of the problems are genuine, where during delivery or post-delivery, mother is not well or mother expires, right? Or due to some reason, the mother is unable to feed the baby, especially preterm baby. Preterm baby means less than 37 weeks. And for preterm babies, breast milk is very, very vital for survival. For a preterm baby, if you don't give breast milk, the chances of developing sepsis, the chance of developing necrotizing enterocolitis, NEC, or more. Next. So if mother's own milk is unavailable or insufficient, insufficient is also subjective, right? So all these mothers can be actually be counseled. The next best option is use pasteurized donor human milk. So just like we are getting commercial cow's milk, pasteurized milk, we can do it in a smaller way in settings where in all delivery points. I'm not saying that every delivery point should have a human milk bank. So depending on the load, there can be a central point where there can be pasteurization, and other delivery points in and around that district hospital also can network, and it can be the same facility can be used. PDHM provides vulnerable neonates nutritional, immunological, and growth factors when mother's own milk is not available or delayed. We know pasteurization can bring down the macronutrients and the immunological composition to a certain extent. But having said so, even after pasteurization, that is 1,000 times better than giving formula to the child. Next. So the world's first human milk bank was started in Vienna, Austria in 1909. In India, actually, it was started in 1989 itself in Sion, Mumbai by Dr. Armida Fernandez. So even after 25, 30 years of starting the first milk bank, the number of milk banks in the country were actually less. So even for 5, 6 years back also, numbers were only 40 to 50 only. Simple reason was formula. You go to any corner of the country, even without a prescription, you can get it over the counter. Whereas simple thing, which is more physiological, human milk bank, people were not aware. We have heard of blood bank, but what is this human milk bank? Next. So it's just a comparison. You see here one picture of India, where you see some of the red areas and green areas. Red areas where the neonatal mortality is more, and the green areas are the area where the neonatal mortality is less. And the location of milk banks. This is fairly from 2017 data. So if you see here, those areas with increased neonatal mortality, there are less human milk banks there. Whereas those where there are milk banks are found, the neonatal mortality is less. I will not say that human milk bank alone is bringing down the neonatal mortality, but actually it should be the reverse way. Wherever there is more mortality, we should bring in more milk banks, and you should improve exclusive breastfeeding. Next. Yeah. What is the rationale for using donor milk? The donor milk provides nutritional and immunological benefits which a formula will not give. And as I said, for preterm and low birth weight babies, it is very, very vital. Next, please. So PDHM decreases NEC, just like Nelson will give a long list of conditions which are benefit for the baby. Similarly, pasteurized donor human milk also does the same thing. One is NEC. Next. Decreases sepsis. Next. And bronchopulmonary dysplasia for preterm babies. They also have lower incidence of bronchopulmonary dysplasia. Next. So you may think that human milk banks are competitors for exclusive breastfeeding. That's not the case. People, they have actually scientifically proven that wherever centers there are human milk banks are established, the exclusive breastfeeding rates have actually increased. We have our own experience in JIPMER, which I'll be sharing. That's because it's like a symbiotic effect or a ripple effect in the community. Once you ask the mothers to exclusively breastfeed, they'll also come forward for donating for the milk bank and vice versa. Next. So SARS was a scare. Good thing it has gone away. But even during the pandemic, we were staunchly supporting exclusive breastfeeding, and we did a small study where we proved that the virus is not viable in the express breast milk which the mothers were giving. So some of the centers were unnecessarily separating the mothers and babies initially, but of course in the subsequent waves the concepts were clear and mother and baby were together. So what I'm trying to say is, even in the disaster scenarios or pandemic scenarios, we should always support breastfeeding, and we should not use it like as an excuse to stop breastfeeding. Next. So who are the donor population who can donate milk to the milk bank, right? So any healthy lactating mother can donate to the milk bank. Any healthy lactating mother can give, right? The donor can be the postnatal mothers in the wards. They, after feeding their baby, some of them think that by giving milk to the milk bank, their own secretions for their own baby will decrease. That's not the case. The more you express out, the more the production. So the more the breast milk is expressed from the breast, the production of the milk increases. This is a important health education message we should circulate. Lactating working staff in the hospital can also be potential donors for the mothers. There are centers where people, just like blood camps, blood collection camps, people in Rajasthan go to the community, collect the milk and come. Actually, Brazil is way ahead in human milk banking. There, it is percolated in the community. The mother feeds the baby at home, extra milk she pumps and throws out. The postman, the fireman, everyone take it to the nearby pasteurizing center. So it is fantastic. The human milk banking is fantastically working in Brazil, and formula use is literally nil. Next. So of course, there are some contraindications, HIV, hepatitis B, etc. If the mother is prone to have or she is acutely ill, she cannot donate the baby. So that's why we always pre-screen the mother before taking it, including the window period also. Next. So who are the recipients? So I would like to reiterate the fact that every drop of donor milk collected is like gold. Today, tomato may be gold, but actually breast milk is gold. So we should not unnecessarily waste breast milk. So we cannot give it to every baby who is saying not enough milk, you give milk from the milk bank. It should be prioritized for preterm babies, sick babies, babies who are more prone for NEC, or a mother has expired, or due to some reason, the mother is not in our setting, we found that the post-LSCS mothers, due to some reason, in the letdown thing comes a bit later than the SVD mothers. So if we allow them, if we can take over by the human milk bank for a few days, till their letdown comes, then it's really beneficial, because if we do not support them at that point, those are the mothers who directly switch over to formula. So this, for the transition use also we can use. So I'm saying that giving human milk from the human milk bank is not a permanent solution. It's a transient way which we can make more mothers exclusively breastfeed. Next. Of course, there should be a structured unit for maintaining a blood bank. The important thing is a lactational counselor. Imagine a blood bank without blood. What's the point in having a bank? Similarly, it is very easy to start a human milk bank, but the most important thing is counseling and motivate the donors and getting enough donor milk. So that is the key point in a human milk bank. Next. So this is our team. Actually, we didn't, being in government sector, we don't have the luxury of having lactational counselors. Whatever the hospital staff we got, we have trained them. Actually, they are bachelors in physics and non-medical subjects. Still, we are able to train them in counseling and being them with a team leader of a nurse. So we are able to run the show, right? So for breastfeeding, we should go away from the concept that it is a duty of a doctor or a nurse. It's a duty of the community. Next. So these are the common equipments which are needed. The key equipment is a pasteurizer. The conventional pasteurizers are costly. We can do it with a shaker water bath, which can actually do the work of a pasteurizer. Of course, a deep freezer where we can store the frozen milk for a month together. But of course, ours is a turnover is more, so we won't be storing for longer than a few weeks. Refrigerator and autoclave facilities, most of the hospitals we are having. The important equipment, next important is the breast milk pumps, because they found that manual expression, the amount of milk collected is less. Whereas once you use breast milk pumps, the amount of milk collected is good. So in centers where donor human milk banks are there, enough breast milk pumps should be there. And of course, containers. We don't go for plastic containers. We always, in our country like ours, most of the centers in India are using stainless steel containers, wide mouth stainless steel containers, which are easy to sterilize. Next. So these are the steps which are used in human milk banking. We screen the donor mothers, both from the history and a quick examination. Then the milk is collected. When we actually do a process of pooling, meaning one mother will give 5 ml of milk, other mother will give 100 ml of milk, they'll come at different timings. So we cannot keep on collecting individual milk samples. So we'll be pooling them together. There are advantages of pooling and disadvantages of pooling. Advantage in the sense, once you mix term milk and preterm milk has got more protein, term milk has got less protein, and somehow there is some homogenization and average content of protein for the milk. But these are the days where we are evolving. We are trying to stratify the pooling. Say, for example, the protein requirements for a 28-weeker to 38-weeker will be different compared to a 36-weeker. So we can stratify the donors and collect the milk. After collecting the milk, we do the pasteurization. Post-pasteurization, we test them, whether there are any colony counts, right? Some of the countries, they do pre-pasteurization also, but there is a lot of wastage of milk in that. So we don't do pre-pasteurization testing. We do only post-pasteurization testing. And once we are sure that there is no growth, then it is prescribed to the baby, right? Next. So this is where our collection room, where you can see the breast milk pump and the staff nurse there, and mother is expressing the milk. So it should also be made convenient. They need not come all the way from their postnatal ward to the mother. We can give the pumps to the concerned wards and we can transport the milk. Next. So this is the shaker water bath or the pasteurizer. It's a simple thing. We use Holder's pasteurization. We heat for 62.5 degrees Celsius for 30 minutes and then cool it. A simple pasteurization technique, but holds good. Most of the bacteria, virus, everything is killed. And so far, everything is fine for us. As long as we take all aseptic precautions and the pasteurization is correct, there will not be any contamination in the human milk, because breast milk itself is almost nothing can grow easily in a breast milk, right? Because it has got a lot of cellular components. Next. So as I said, the Holder's pasteurization, it can decrease the IgA and secretory IgA concentration activity, and some of the cytokines and lactoferrins can also decrease, and the complete loss of lipase activity. But despite all this, it is still 1,000 times better than a formula. Next. So this is snapshots of the period where we did a lot of quality improvement initiatives, and we were able to collect enough milk, and we were also sharing with the peds surgery ward also. Next. So a quick run through the temperatures. So fresh raw milk can be stored up to 6 hours in the room temperature. Fresh unpasteurized milk up to 24 hours in the fridge. Once you have pasteurized milk and store it as minus 20 degrees Celsius, that's where the ILRs come in place. Minus 20 deep freezers. Minus 20 degrees Celsius, you can store unpasteurized milk for 3 months and pasteurized milk for even 6 months. Next. So we do the colony counts using the conventional methods. There are different methods, but we do it conventionally. Next. Yeah. So this is one equipment where the research community will be interested. So this is the human milk analyzer. It is like an ABG machine, right? So actually we can something called as targeted fortification, where you can actually test the mother's milk, see what is deficient, and accordingly you can fortify the milk. So for testing the human milk macronutrient composition, this human milk analyzer uses infrared technology. It's not a very essential equipment for every milk bank, but those milk banks which do fortification strategies, it will be useful. Human milk analyzer along with the sonication equipment. Next. So next slide. Yeah, so this we opened our human milk bank almost 7 years back. We labeled it as Amudam Taipal Mayam. In short, ATM. Once we labeled as ATM, it was very catchy. People thought it's something to do with money, but actually there is no money involved, both for donation as well as for receiving. So ATM is the name. It's just not the milk bank. We also do the breastfeeding counseling services. Right, once there was demonetization some time back, all the ATMs were down. Only our ATM was functioning. Next. So I'll share with you some of the data from research work which we have done from our as part of my part-time PhD work. So we saw the incidence of neonatal mortality, NEC, and the rate of exclusive breastfeeding before and after the opening the milk bank. Next slide, please. So we found that neonatal mortality has decreased and the exclusive breastfeeding rate, as I said, actually has increased. So though some of them have not said, that's always a trend for them. So NEC decreases, neonatal mortality decreases, and exclusive breastfeeding increases. Next. Then we did an RCT with using standard fortification for pasteurized donor human milk, because we always think that by fortifying and introducing the whatever commercially available fortifiers, we think that there's always chance of NEC, but without fortification, their weight gain is not good. So there is a clinical equipoise is there. So we did that, and we found that even fortification with for pasteurized donor human milk was safe, and there was no increased incidence of NEC. Next. And of course, the effect of Holder pasteurization, we studied the composition of macronutrients as well as immunological profile. There was, of course, some decrease with the Holder pasteurization. Next. So we did some of the qualitative work along with our nursing staff regarding the beliefs and what does the donor feel, how does the recipient feel. Responses were really fantastic. Ours is a highly evolved society. There were practically no religion or caste or any other dividends which came in for milk donation or for receiving milk. Of course, there were some efforts that in the private sector, they were trying to sell human milk. Then they were trying to commercialize donor human milk, which is a wrong thing, of course, because of a lot of activity of NNF, IAB, BPNA, and that they have stopped producing that Prolacta, which is that product where they were trying to commercialize human milk, which could have taken, because once you start commercializing donor milk, people will never come to a government sector for donating it free. They will sell it online. And worst thing is, those preterm babies whose mouth and whose stomachs are hungry will not get the milk. Whereas for non-specific reasons, for 1001 reasons, other than preterm babies, they were misusing the breast milk. So it should never be commercialized. Next. So it's not important that you just inaugurate a human milk bank and forget it. Constantly, we need to review what's happening, what is the donation numbers, and what are the obstacles, how can we improve it. One Dr. Sindhu was with us, a fantastic clinician and neonatologist. So with her help, we were able to do a lot of QA activities where we were able to improve the daily collection of donor human milk. Next. Even during COVID, we were able to do a wonderful job. Next slide, please. So networking with the postnatal ward sisters, having daily pointers like a board, a simple board, and frequent meetings of the different stakeholders, we were able to improve the donor milk collection. So what I mean to say is, for that matter, any neonatology aspect, QA activity should be inbuilt in the system. Next. So there are a lot of guidelines. We follow the IAP guidelines for human milk banking, but it's always a gray area. Is human milk a drug or is just a nutritive product? It contains stem cells. So does it come under the regulations of stem cells? So, and as per WHO, it's an essential drug. So we need to, there are a few more years will take so that we evolve correct consensus how to use human milk and how not to use it unscrupulously. Next. As I said earlier, exclusive breastfeeding, kangaroo mother care, and human donor milk, all these things go hand in hand, and all these things will be supporting each other. Next. The government sector has also brought out wonderful programs. Mother's Absolute Affection, MA program, the Lakshya initiative, where for the delivery room initiative for improving the early initiation of breastfeeding, and national guidelines on lactation management centers are also there. But more awareness should be there, and more training is needed in all these areas. So a lot of things just are in paper, it should be in practice. Next. So as I said earlier, I touched upon this formula industry. This is also from the recent Lancet series on breastfeeding. The misleading advertisement, commercial formula industry, and vested interest and their economic interests are all inbuilt in the system. Even for post-tsunami disasters, a lot of areas they were trying to flood the commercial formula which were near expiry. Those mothers who were actually feeding stopped feeding and then started using formula. So such is the vested interest of formula, which the public should be aware of, and we should never support formula industry, and we should not take any donations from them for any conference or so. Next. Okay, last few slides. So from the government side, we should have stringent laws to enact them, and from the society, the awareness also should be there. The key points which I would like to say is encourage use of mother's own milk and avoid formula, human milk banking and voluntary milk donation. Voluntary is very important. Increased awareness is needed. More human milk banks need to be for the amount of number of deliveries and the increased neonatal output. So human milk banks should be increased, and there should be developing networking among themselves. Promotion of exclusive breastfeeding and KMC will improve voluntary milk donation. Research on our own pasteurization and fortification strategy in the Indian context should be encouraged. Next. So this is one statement from WHO actually. In all mammalian species, the reproductive cycle comprises both pregnancy and breastfeeding. In the absence of latter, none of these species, man included, could have survived. So this is fact. So each one of us have a responsibility to promote exclusive breastfeeding. There's nothing shy, you need to feel shy about this work because it's a life-saving thing. Next. So we should not talk for breastfeeding for just for 7 days and forget it. All 365 days, we should talk about breastfeeding, and at least few minutes we spend with your mother, make sure she feeds, will go a long way for both the mother and the baby. Next. Thank you.
I have two questions, not questions, but clarity. One is you said fortification.
Yes.
You mentioned about fortification. Yeah. Well, it's a very good talk. I enjoyed it and it was quite informative. I learned quite a few things here, although I'm a clinical person. Medical. First is about fortification. You said macronutrient analysis and fortification. Does it mean proteins you would like to add protein to the milk?
Yeah.
And second point is, did you measure the growth of these infants? If there is growth faltering, what is your take? Do you advise going for other milk or
It's an important question, ma'am. There are various fortification strategies. Of late, we are following standard fortification. The commercially available human milk fortifiers, we add 25 ml of milk to each sachet. That's how it's going. That's called standard fortification, irrespective of the composition of the milk, because there is a dynamic change in composition of the milk depending on the day, depending on the gestation. But despite that, we use standard fortification. What I was trying to tell about was targeted fortification, where you can actually measure and then change the composition. You are very right, because when we talk of growth of the baby, it is just not the carbohydrate or the calories, it's the protein content which is the priority. So we need to supplement proteins. The commercially available fortifiers also have protein. Sometimes they have brought in human milk-based human milk fortifiers, meaning
you add protein?
It has proteins.
It has protein, but you fortify it with more protein.
Exactly, ma'am. That's yeah. But the only thing is that there is always a chance of NEC. We need to strike a balance between NEC and growth of babies, right? So that should be the case. So, but targeted fortification is a costly affair. But still, standard fortification strategies can be improved. And that's the reason we should say that for preterm babies, when you are substituting, another preterm milk will be the best thing rather than giving term milk for that baby. The second question was regarding the growth parameters. That's very, very important, ma'am. Suppose we don't advise fortification for all the babies. Usually those babies who are less than 1,800 grams, right? Despite our strategies, they are not gaining weight only, then we advise fortification, right? So by advising fortification, most of these babies gain weight. And we don't continue fortification forever. So once they have satisfactory weight gain, we stop fortification and they are on their own.
Growth faltering, I asked you. When you find some child is not
exactly, ma'am. So there, starting fortification immediately for growth faltering is not the case. We need to find out, is the mother feeding adequately? Is the position correct? Is the attachment correct? Right? So is she giving any pre-lacteal things? Right? Is the baby having any other illness apart from nutrition, which is causing growth faltering? So, and plus counseling the mothers. All this should be satisfied before going for fortification.
They're saying only fortification, but now we have enough information that in clinical sector, many pediatricians right away recommend formula milk, justifying that the baby is not growing up to that level that is required.
We are part of the...
They need to be counseled, or are they right?
Obviously.
Because again, there are two situations, public health and clinical. They say clinical situation, it is right, you can recommend, because the pediatrician felt that it is required.
It's a dicey situation. I will say that 100% we may not stop formula, but the number of babies who receive formula should be very, very minimal. So that's what I'm saying. So even when it comes to fortification, then they compare the cost of different formula versus the commercial fortifiers. They play with the cost. So, but in practice, formula is not good and it's not the answer. We should be as physiological as possible.
Appreciated if your answer was not 100% effort.
Yeah.
100% you're not recommending formula. You still can try with this.
Yeah.
One question.
For pediatrician. There are other questions on this.
Sir, the question is regarding my questions are two regarding this thing, your presentation. So first was, you were saying that in some others, most of the cases, the inadequacy of milk extraction is due to reasons like the caused by the participant. But in some cases where the lactational failure happens, in that case, can recombinant human prolactin can be used? Second question. You were saying regarding that.
I'll try to forget. I'll answer yours first. The thing is, for relactation, there are different lactation techniques. Even a mother, an elderly mother who delivers a baby, can be made to lactate, but even without hormonal interventions, just by there are a lot of relactation technique, drip technique is there, right? That, but the main medicine there is also is counseling. So we need not jump to hormones straight away.
So second question is that regarding the pasteurization of breast milk, you were saying that in that case IgA has been reduced and there is a complete degradation of lipase happening over there. So in that cases, are there any studies that is being compared with normally breastfed babies and these babies who are fed with it, and what is their immunological performance in that cases? And the lipase related.
Yeah, it's an important thing that lipase is important for digestion of the other nutrients of the baby. There are a number of studies which have shown that the babies on pasteurized donor milk, their growth parameters may not be equal to the mother's own milk, 100% sure. However, these pasteurized donor human milk is not given for a longer duration. For even those mothers, once we give PDHM, and then tied over with their mother's own milk, we always encourage them to be on completely on mother's own milk. This is a temporary stopgap arrangement so that the mother doesn't go to formula, as simple as that.
Because that cases are complete lactational failure cases related things.
That's what. So by labeling as completely lactational cases, there will be actually 99 mothers in that 100 mothers who will benefit from counseling. Any mother born with a breast can breastfeed. Only those mothers without any breast may not breastfeed, as simple as that.
Just have a layman's question. When breast milk banks are available, commercial or non-commercial, when a particular container has mother's milk, and then is it labeled by any chance? If so, does it come under food labeling or does it come under? Because on a label, everything is to be given, how it is to be preserved, how it is to be kept when it is open. So all those things are to be given if it's a food label.
Correct.
So is it coming under any regulation? As far as I know, it is currently not coming under food labeling regulation.
Exactly. So we have, as of now, IAP guidelines, the EMBA guidelines, European Milk Bank Association. These are the standard guidelines which are used. Technically speaking, we are not labeling like that. Ideally, the mother who is receiving should not know who has actually donated. Though the registry will be maintained, that will not be explicit, but for the internal process of collection, those labeling will be there.
Sorry, I'm not talking about who's donating. I'm talking about the label on the container as to that this is human milk and this has this nutritional value. If it is fortified, with what it is fortified. And then what are the regular food label that usually has? Like how it is to be maintained.
I agree, sir. We have not reached that stage yet. We will come to that stage because, say, for example, TPN solutions, total parental nutrition, we still ask our PGs to prepare it under aseptic technique, and then we are giving it. Whereas in the Western setting, we just order it. This is the baby's weight, this is the baby's protein requirement, and it automatically comes from the pharmacy with the label, just like any other drug. So we will come to that situation, but in the process, commercialization should not occur. But in our setup, we know at least when this batch of milk is collected, when it is sent for pasteurization, when pasteurization was done, when pasteurization testing was done, those things are meticulously documented. And we do pooling, sir. We are not collecting from individual mothers. Pooling in the sense I explained to you by combining. Yeah, so that's what we are doing.
I get all the basic thing like expiration date and
exactly
are must on
such obviously, sir. Obviously.
That's the reason why
but from again, the labeling should not go to the extent of how much carbohydrate,
no.
Because there is no interference.
Correct.
Interference. You naturally collect and preserve it.
Exactly.
There's no need to add extra information and unnecessarily.
Agree.
So generally, if it is
Because it is
fortified, it
not
should be-
commercially produced.
Yeah.
It's a natural.
Agreed. The debate can go on, sir, whether it's a drug, which regulation, etc. But it will take more time because there are stem cells also in it, right? So all the rules which you apply for stem cell therapy or research should also apply on breast milk.
So we have two online questions. We have one from Dr. Sylvia Rao, who says, is composition of milk related to the mother's nutrition status and or mother's current diet? Can you answer this?
So actually it is related to both. Previously, the older study said that it is irrespective of the malnutrition status of the mother, the nutrient quantity of milk doesn't decrease. But over a period, if the mother is malnourished, then the macronutrient composition is likely to change. There is something interesting called as the enteromammary axis, the gut mammary axis. Indirectly, the mother's gut is connected to the baby's gut through the breast. That is, whatever bacteria which goes inside the mother's gut, antibodies are produced, IgA is produced, that IgA reaches the mother's breast, converted to, the IgA is a protein, right? So it should not be absorbed or digested by the baby. So it becomes secretory IgA. So even some of the research is going on about even viable bacteria which is going on. So this enteromammary axis is there. So obviously the diet, the infection of the mother, everything has a say on the baby. But in general, whatever infections the mother has, the baby actually is protected. Say for H1N1, the Western data said that more the younger population will be affected. None of our babies were affected by H1N1. COVID, there was a scare. All the babies were healthy, drinking COVID mother's milk. And we technically also documented there is no viable virus inside. Some of the PCR fragments of the virus could be there, but no viable virus was inside. So indirectly saying, whatever infection the mother gets, baby gets the antibodies.
There's another question from Dr. Vikas Kaushal about bonding agents. Are you aware of the initiatives?
So actually, I told you it's our own initiative.
Sorry.
It's something similar to Lakshya initiative. I believe every center should have that.
Yeah, I'm sorry. It's a SOP.
Yeah, it's published in Indian Pediatrics.
That's what is so that they can be implemented.
Yes.
Definitely, I can.
In other
That's what they
hospitals,
ask.
very good.
I have shared it, sir. It's published data is in Indian Pediatrics. You go to Google and type bonding angel, Jipmer, you'll get the
First question.
yeah.
SOP.
SOP also, we can share it with you.
I'm sorry that I have been moving outside a bit, so I could not catch up some of the presentation. Excellent presentation.
Thank you.
And so we'll have a break and then we'll just.
Thank you very much. Kind of you.
And I request we'll have a tea break of 15 minutes. We'll join back again. And for the online audience participants, we also have a quiz competition after coming back in 15 minutes. And the first two participants will be receiving the mementos. It's a cup and the logo of the band is on the cup, which is being given to all the speakers and panelists. So you will receive those. The first two participants who have got the highest mark in quiz will get that. Thank you all.
You said you'll be giving the mementos.
I'll do that. I'll do that.
This is only for those participating online.
Online and offline. Just to meet. That's not better.
Excuse me, those who have joined, you can see the code. There is a code. So this is a very interesting, session we are now starting. Requesting everyone to open your mobile, and in the browser you have to type menti.com, and after typing menti.com, this is the code you have to put in your mobile. Requesting those who are outside to please come in. We will start soon. And those who have already inside the seminar hall, take the advantage of setting up your mobile. And those who are joining online should also join, because interesting prize gifts are there for the first 2 participants, preferably one from this hall and another one from those who are joining online. And we will start soon. Is it coming in the Zoom as well?
Yes, sir.
Online? Yeah. Not this. So far, 21 people have joined. We can see these thumbs ups are coming. And after you put put this code, after typing menti.com, and then you put this code, then there will be some thumbs up. So that we know that people have joined. 23 people have joined. Let's wait a minute. And in the meantime, I'll just like to thank Dr. Siswan, everyone, and I am specifically for giving this platform and doing this as a valedictory session, because we are closing the first week of August, and this is a celebration that we are doing. Of course, to tell you that this is not the end of the awareness or the sensitization around breastfeeding. This has to continue 365 days, but some bit of sensitization, if you can take this out from this room to the community, that will be very, very helpful. Shall we start, or are there others joining? They're joining actually. I don't know how many are there in online. 91 participants are there. We have so far registered 30 only. So let's give a minute so that we give justice to everyone who are there. And everyone should get a fair chance to get a prize. Fine. So this code will be there, always visible. So those who haven't joined yet can always join. So, and in the next 2 slides, it will ask you to give your name. So you can give a nickname or your full name, doesn't matter, but end of the quiz you have to identify yourself. So that's why a name is needed, right? It's a very interesting quote. Somebody from the World Bank in 2016 said about it that if breastfeeding didn't exist earlier, someone who invented it now should get a double Nobel Prize. One is in medicine, another is in economics. Such a profound statement. This being a life-saving tool, and as well as a hugely impacting cost-saving, healthcare cost, other kind of cost, economy, GDP, everything, around it. So, fine. So many of you have learned about the fastest finger first. It's a kind of a KBC tool. So these are people who have joined. You must have chosen your emoji or icon and given a name. So there will be total 6 questions. It's not about answering the correct question. It's also about answering super fast so that you get good marks. Okay. Okay. So answer first to, this is the question. What is the prelacteal feeding? There will be options. You have to tick the right thing in your mobile. Time is ticking. Okay. 9, 8, 7, 5, 4, 3, 2, and we're done. So this is the correct answer. That is, you can see in the screen and reflect that have you done it right or not. Okay. So we will see who is scoring higher. Okay. These are your names. Who is Amy? Oh, wow. So we have someone in the hall to grab the prize. Okay, the next question. Breastfeeding helps to protect mothers from diabetes, breast cancer, and ovarian cancer. True or false?
Don't say the answer.
No, I'm not saying.
No, for them.
Aisha, okay, right.
Someone else is giving the answer.
That's true or false. Very simple. I think we can invite the other staff also. They can answer many questions. Right? So this is true. 100% people have said, answered it very correctly. Okay. Is it still MA who is leading or? Yes, fastest finger first. Okay. Next question. Most mothers can produce enough milk for their babies. True or false? What happened? Problem process. Reloading. Okay. So only 3 people who couldn't answer it correctly. They're thinking that it's not true that most mothers can produce enough milk. No problem. We will clarify these points in the upcoming sessions. Raghavendra ji. Who is Raghavendra? Is he okay inside the hall? Very good. Right. The next 2 questions will be a little tricky, so be very mindful and
Second innings, the pitch is little very board and tone.
which hormones is responsible for breast milk production? Progesterone, oxytocin, prolactin, estrogen. I think there is a spelling mistake in estrogen, but never mind. Out of this 4 hormones, which one is responsible for milk production? Okay.
They understood the essence of it. No issue.
Okay. Very good. Majority have responded correctly. Raghavendra, then Sylvia, then MA. Oh, no. MA is first. Sorry. Question 5 out of 6. How can a breastfeeding mother increase her milk supply? 3 options: supplement with formula, decreasing fluid intake, breastfeeding more frequently. I think the previous presenter, doctor, was explaining this. Still, there are 2 people who couldn't guess it correctly. Not a problem. Okay, so online people are also trying hard, but I guess people here are more smarter. Last question for this quiz thing. What might enable a working mother to breastfeed her baby? Very similar to the theme today. Paid maternity leave, workplace provision, flexible working hours after maternity leaves, all of the above. Okay. Very good. Then there are 2 grace questions, and here there will not be any scoring or ranking, but this is it. So we are now declaring the MA is the first prize.
Randomly.
MA.
Oh, madam. Sorry, I'm very sorry.
Next. And then the second is VA. I don't know who's.
Oh,
okay. This is the one. So after this session, we will give you the prize. But it is not ending here. There are 2 more audience poll kind of thing. Can you see what could be the healthcare cost that could be saved due to appropriate breastfeeding in India? You have so there is a range, and the answer is in crores. So you have to give an estimate. And the moment you give some estimate, it will give you a confidence interval, a bell-shaped curve.
It's already happening.
It's already happening. People are responding. The correct answer you will get to know immediately after this session. What is that cost? Healthcare cost. Okay, good. So good guess. It is more towards 1,000. That's for sure. Very, very nice. Maybe around 800, 900. That's the mean. Not bad. Okay. The last one. Tell me whether true or false for each of the 4 following questions. First one is, there is an act and a penal code to prohibit advertisement of breast milk substitute in India. True or false? Bal Raksha Bharat, that's Save the Children. That's the organization I belong to. Cannot take grant from companies who produce and promote breast milk substitute. This is something we did it internally for our employees, but it's true for NIN as well. It's true for all organizations. Third question is, doctors can be fined up to 5,000 and or up to 3 years of jail by violating this act. True or false? And last is, most of the babies need breast milk substitute in the first 6 months. True or false? What is your reading by seeing this pie chart? What do you think? Majority have answered correctly or no? In the last pie chart, it's the no percentage should be more. That's coming correctly. And in the first 3 pie chart, the yes percentage should be more. Right? That's the correct response. So, okay. So this is it. How can we support the community to promote breastfeeding? If you can just mention few things, few keywords, that would be interesting. We will take a screenshot of it for our own, documentation purpose. Are you all, writing already? आप उसको डाल रहे हैं? Is it coming on your mobile? This particular question? Okay. Word cloud जिसको बोलते हैं हम. So the word that comes bold, prominent, bigger is the word having maximum frequency. Okay. Nice. So we are talking about counseling awareness. So basically communication. Dr. Subbarao is busy and must be happy looking at this. Okay. So we are ending it. Thank you very much. And I think you recognize those two
Yes.
colleagues who need to get the prize. Thank you. Shall we share? Shall we? Is it coming?
Is the virtual participants, is there a delay for them? Why could we answer?
So we are here. Okay, so some of the questions will be answered here as well in the upcoming session. You must have seen that 17 SDG, how all the SDGs are connected with breastfeeding, and breastfeeding can impact and attribute and influence all 17 SDG. In other words, if there is problem with the other, the 17 SDGs, breastfeeding can also be impacted. So it's a bi-directional relationship with all the variable and the constructs that are there in all 17 SDG. And breastfeeding is a central theme and a very connecting, construct to it. So it's a, no-brainer. And that's how it says how important it is. If you look at the, prevalence of breastfeeding from a global perspective, you would see that, okay, nice this. Yeah. No, that's fine. So the scaling up of breastfeeding to an optimal level can save 20,000 maternal deaths, 8,23,000 child deaths every year globally. And we will come back to India, how much it can contribute. And at a global level, it can save $341 billion every year. But in the quiz, the question was about India, not about the global thing. So we will come back to that. So I'm not going into detail, but yes, all the indicator around breastfeeding is falling and it is off track from the global indicator and the target, right? From India, if we look at the prevalence around breastfeeding, this is NFHS 4 and 5. You can see again there are some indicators which should have been much better than this. Say for example, early initiation of breastfeeding, there is hardly any increase in the last 10 years from NFHS 4 to 5 until now also. Although our institutional delivery has increased, there was a time it was less than 50%. Now it is very close to 90% of institutional delivery, but still only 40% children are put to breast in the first golden hour. That means there is a problem that is happening even in hospital, be it public hospital or private hospital. So many people blame it for cesarean section ho raha hai, isliye nahi ho raha hai. But how many percentage of deliveries are actually happening with cesarean section? Technically, whatever cesarean sections are happening, it's already a very inflated practice. Technically, it should be less. And you can see that in private hospital, the CS sections are more than the public hospital. But even in CS sections, as doctor said and explained, there are ways and there are means you can initiate breastfeeding in the first hour. So there is no excuse that it is happening because of the cesarean section. There is no excuse that our doctors are not trained or staff nurses are not trained. Born angels are not there. We can create an ecosystem and atmosphere through which this very vital practice need to be supported. That's number one. If you look at the state-wise parameter from NFHS 4 to 5, the blue one is NFHS 5 and the line is NFHS 4. You will see in some states things have increased, and in some states it has decreased, and nationally it is 41.9% or 42%. Same thing, exclusive breastfeeding from all these states from NFHS 4 to 5. There is marginal improvement in some states, and there is some decrease in the some states. But I will come again to this particular slide to explain that this is just exclusive breastfeeding. What is the definition of exclusive breastfeeding from a metric point of view, from a survey indicator point of view? Exclusive breastfeeding is what? You are having only breast milk and nothing else. That is exclusive breastfeeding. How about you are having it only 2 times a day? Your survey indicator will be tick. You complied to exclusive breastfeeding. Is that good? Nandurbar is a district having an exclusive breastfeeding of 85%, and that is the same district having a malnutrition of 65%. So these two things can coexist. So that means exclusive breastfeeding is not good enough. Effective exclusive breastfeeding is the requirement. So that means you are not only doing exclusive breastfeeding, but you are also maintaining 8 to 10 times or as frequently as possible or as needed. But that becomes difficult to measure and difficult to track. Probably that's why NFHS has a very simple screening indicator, but this is not an aspirational indicator. That's my point of putting it here. So please be mindful that there is a quality attached to it, and we need to get there. Okay, so I will now invite Dr. Sriswan to explain further, and then I will come again.
Yeah, thank you. So as this theme of the consultation is about bridging the evidence gap, as a scientist from ICMR and 9, it's our duty to actually generate the evidence and present the evidence as it is using systematic reviews. But for this, this is a part of the systematic reviews we'll be planning in the long run. By next year, I hope with the same audience, I'll be presenting a systematic review of all the breastfeeding evidences, not only systematic reviews, but overview of all systematic reviews. So we have been doing this work since last 1 year. Because I have only 2 students, so I've been working with them. And you can see that what are the main themes of systematic reviews, if you can see in the last 1 year. So there are about 15,000 articles on breastfeeding and IVF practices globally in LMIC countries. So you have to sit through all the articles, read the abstracts, and then make your themes. But that's the larger work. That's the work we'll be taking on. But for the moment, we have taken the last 1 year work because every year we have this theme. So let's see what new evidence has been generated in the last 1 year in the area of systematic reviews. So we have the main themes here. The first theme is in the breastfeeding programs and interventions. We're talking about the bonding ageless program. So all those new programs that happen across the country are documented, and what new evidence is generated and new interventions that happen. And also the next theme is the problems in breastfeeding. What are the common problems in breastfeeding and how do we manage? And breastfeeding in difficult situations. One problem in breastfeeding is about the perceived milk insufficiency that I'll be talking about in more detail. And of course, breastfeeding in difficult situations like HIV, be it in other situations where tongue tie. So all these situations, how do mothers breathe and what are the current evidence on it? And of course, the most important one, the breastfeeding education, the lowest cost for the maximum benefit. As Dr. Antaramida said, that you can have both Nobel Prize in medicine as well as economics for breastfeeding education. And the last, of course, the benefits of breastfeeding. So these are the number of systematic reviews in the last 1 year we have done. And you can see that about more than 50 articles are in the area of problems in breastfeeding. What are the factors that affect? What is the management that is being done? And we have we have more than 50 articles, systematic reviews. This is not any normal articles. These are detailed articles and across the globe. How many we have? Breastfeeding in difficult situation, breastfeeding program and interventions, benefits of breastfeeding, and of course factors affecting breast milk composition. It's in much more detail here. And we have breastfeeding education, about less than 20 articles. And we also have few articles on breast milk substitutes. And this is an area of controversy, as the director said, that should we give breast milk substitutes? What should be the law? So people are aware of it. And then we have breastfeeding in working women, because this is the theme we wanted to separate, and we'll be talking about more what is the evidence on this, and maternal and parental role, because it's not just the mother, what's about the father, the other, the entire family. So this, we have few articles, few systematic reviews on this as well. Within the themes, we have a lot of sub-themes. I'll not go into sub-themes. The themes were made from these sub-themes, but within each theme, I would say that these are the commonest sub-themes we have found. First is the breastfeeding interventions and programs. You could see that the most important thing, there's sub-themes on online peer support group. So there is a benefit. NIC interventions, there is a benefit. Knowledgeable support staff. So again, the more knowledge you have, the more it depends on the doctor who is counseling. So that would add further value to your improvement in breastfeeding counseling. We have interventions during natural disasters. The difficult one, how do we reestablish breastfeeding, and what is the evidence for that, and what are the interventions in late preterm and early term, and what are the interventions to adolescent mothers, and what are the experiences of these implementation and skin-to-skin contact interventions. So these were the themes identified in much more detail, and we are currently working on the details of this. And the second theme is the problems and management in breastfeeding, again, perceived milk insufficiency. And I would just like to state that we have further dig down on the perceived milk insufficiency. Now, people say that why do mothers stop breastfeeding? The two commonest factors are, one is the working mother, the second is the perceived milk insufficiency. So why does it happen? Now, evidence says that only 5% of all perceived milk insufficiency is because of primary lactation failure, and 95% is perceived milk insufficiency. So how do we come to about it? And if you look at where does it happen, perceived milk insufficiency happens in the first week of life more than the second part of, in the next from the second month onwards, which means that if you had perceived milk insufficiency, which means you're not able to produce enough milk because the baby is gaining weight, it's not the case. The perceived milk insufficiency is more common in the first month than in the second or third month, which means that it is the knowledge of the mother, it is that she is unable to breastfeed. And most often this happens because in the first 7 days of life, the amount of milk produced is only 60 ml of colostrum. So it is 60 ml compared to 600 ml at the end of 1 month, 600 to 800 ml of breast milk that happens. So mothers should be educated that the amount of milk that is coming in the first few months, the amount of milk that is coming out will increase. So it's very important to identify this, and you can save almost 50% lactation problems just by educating the mother and motivating the mother that your milk is sufficient for the first 7 days. And most often, even the educated mothers think it is not sufficient. So because we have an easy way of accessing formula milk, people start formula, but it's not the case. So we have to educate the mothers that the perceived milk insufficiency is mostly psychological. We also have, again, the other reason for perceived milk insufficiency is also the perception of infant crying. Again, we have a lot of evidence on that, and this is also being presented, and how parents perceive what do those. So once infant cries, the first thing is that, okay, because the baby is crying, maybe the baby's milk is not sufficient. There are other reasons we have to factor out what are the other reasons, and then only decide. So again, it will be less than 5% of all the cases. The new evidence where we don't have enough, the new management of acute malnutrition in infants, especially in the community. These are new studies happening in Ethiopia and also in India by Kalavati Sar Children's Hospital. How do we manage the first 6 months of wasting? When you talk about burden of wasting, but when we talk about Nandurbar district, one example where wasting is high. So how do we manage them? Effective breastfeeding counselings. How can we do that? So there is one trial in the same district by Dr. Rupal Dalal that if you can improve, she has, in her experience, she has said the cross-cradle technique, if you use a cross-cradle technique, and then do intensive counseling, then you can improve underweight as well. So that's her evidence that's coming out, though it's not in the systematic reviews. She's also a collaborator and also collaborators for the IIT Bombay, which Save the Children has the partnership on. We also have evidence on breastfeeding in ventilated infants now. So how should ventilated infants be, what is the evidence on that? We have that. And also context-specific determinants. I know I'll be talking about two context-specific determinants. One is in the if you look at China, in China and Bangladesh, the more the mother is educated, the less likely she's going to breastfeed. So it's culturally, it's important that it's not education alone, but it's also cultural factors that play a role. And also, if the grandmother is more educated, there's also more chances that the mother is not likely to breastfeed. So it is the cultural factors that has to be taken when you actually see the bigger picture. And also, there is some evidence of whether pacifier use. Currently, the evidence is indeterminate. So there's more evidence that is needed on this, whether it affects breastfeeding or not. We have a lot of studies on KP, especially in African countries where still the knowledge on breastfeeding is really poor, and that's the problems we have. We also have themes on women's engagement and motivation. And this is again an important reason for perceived milk insufficiency. Coming to the breastfeeding education, if at all I have to categorize, this is the most important part of all the themes because this is the most cost-effective way of improving breastfeeding. So we can see that breastfeeding, there are two themes we can identify. One is how do we breastfeed, how do we give education to healthcare workers, be it the Anganwadi teachers, ANMs, or the midwives, doctors, social care workers, not only healthcare workers, but the other non-healthcare workers as well. And also breastfeeding education to lactating mothers and fathers. So there's a clear, there's no doubt that no matter how much, whatever way you do, be it through technology, just a mobile message, just digital media, social media, be it the internet, there is a benefit. The benefit increases further, the odds ratio increases further if you can do actually a human interaction, that is telelactation. So telelactation is further beneficial compared to technology alone. This is even more beneficial if you have lactation counselors as well. So the odds of improving your breastfeeding rates increases as it is more personal contacts you have with a mother, be it home visits, be it the visits at the hospital or the subcenter. So the more contacts you have, the more chances the odds of breastfeeding being increased. So this is very important that no matter what you do, every way you choose, there is a positive benefit on improving the breastfeeding outcome. So you can choose a multitude of these factors depending on your own resources. You can use technology, you can use telelactation, you can use lactation counselors, and especially you can use lactation counselors for high-risk cases such as obese women or other women with other problems, especially low birth weight infants. So each way of doing breastfeeding counseling is important, and you can not ignore based on the cost benefits. You can actually add all three of them using a multi-component interventions. So not only just for mothers, but also for fathers. This is another area of key interest in breastfeeding. So these are the themes we have identified, and this is what the evidence says in this area. We also have factors affecting breast milk composition. Again, we have a systematic review on breast milk volume in all the countries together and see how much. So it's now about 680 ml at the first month of life and going up to 500 ml at the 12 months of life. So we have evidence from all the countries, and we can now actually have the data and pool them and see, as Dr. AD has suggested, that how can we actually see that the number of feeding frequencies and the amount produced using the Deuterian technique. Then we could actually devise a formula that this is the amount of breast milk that is important. Breast milk volume is also important in the context of another meta-analysis we have been doing. We'll be talking about in the next slide. But also we have themes on macronutrients, especially the role of lipids, fatty acids. There has been a lot of work in this area, and micronutrients, especially B12 for vegan mothers. There's a new systematic review of vegan mothers. So there is an effect of B12. So that's how do we increase the B12 levels for vegan mothers? So this is one area they could have worked. And also the galactogogues, especially the ginger. And also, and now the other domperidone is actually not so safe is what the new meta-analysis says. So we need to be more aware of what are the natural sources of improving the breast milk output, what are the from through diet. That's also important. And also what are the pharmacokinetics? This is one area that is completely lacking, especially with the use of antihistamines. What is the effect of mother to child transfer in the breast milk, be it the use of anti-tuberculosis drugs, be it the use of anti-malarials, and all the common diseases that happen. What is the mother transmission to the baby? There's a very poor evidence on this, and this is the area we need to focus more and actually have a better confidence for the doctors to say that what happens if you take these drugs to the long-term outcomes of the baby. And also new toxin exposures. We have different toxins that is being available. Some toxins, both natural and artificial, are there. So this is the area of interest for many meta-analysis, and also how to reduce the use of alcohol. What factors affect? Why do breastfeeding mothers still drink alcohol despite its detrimental effect? So these are very important themes that have been identified in this meta-analysis. Again, benefits of breastfeeding, it's limitless. In the words of Dr. Tagore, Rabindranath Tagore, who says that in his first poem in Gitanjali, says that it's my limitless. The ocean of my heart is limitless. So the benefits of breastfeeding is limitless.
There's endless benefits in terms of infectious disease, immune disorders, cardiovascular disease for both mother and baby, postpartum depression, congenital heart diseases, overweight, obesity, endometriosis, child intelligence, and of course, gut microbiota, maternal sleep. This is very surprising that maternal sleep actually, if you breastfeed the baby, you have a better sleep. It's a new finding, and also breastfeeding as a placebo effect for painful procedures. So these are all the benefits of breastfeeding. Undernutrition, as Dr. Adia said, that the evidence is little less, and we need to generate more evidence on that. Maybe Mamicare pathway would have more evidence generated on undernutrition. But one of the most important aspects of undernutrition, that is malnutrition, is the kwashiorkor. As the previous speaker, Dr. Adishesham, said that Cecily Williams has done two great things. I mean, one is the development of, she has identified kwashiorkor and how do we actually treat kwashiorkor. The second is Milk and Murder paper, saying how important breastfeeding is. So we have, there's a lot of controversy whether kwashiorkor is due to protein deficiency. There is some debate on it. So we were working on this systematic review. What is the role of breast milk? Because breast milk is very difficult to quantify. When you say breastfeeding, yes or no, it's not sufficient. Effective breastfeeding is important. How much amount of quality protein is coming from breast milk is very important. So we wanted to see exactly what is the evidence. Why does kwashiorkor happen? Is it because of protein deficiency or not? So we did this systematic review, and we could see that we have collected 74 case report and case series C. The reason we have collected case reports is because case reports have a detailed diet history. Diet history takes a lot of patience. We have to be very careful. We have to know all the things the mother has given. So this is not much more robust in cross-section, but in case reports, you keep asking, probing more questions, and you'll be able to get better case reports. So we have chosen for that. And we also have case control studies to see what are the odds ratio, and we have used the metabin package for the analysis. So these are the mesh forts we have. These are the what you call the Boolean search string we have used. We have used various mesh strings. We used wildcards. So one is the P, the population, infant, children, all the toddler, all the girl, boy. So this comes under the population. And we also have the disease, kwashiorkor, edematous malnutrition, using different terms, fasting, adult times, and of course, finally the diet, be it breastfeeding, be it dietary supplements, or all the other things. So using this search string, we have got all the articles as above described. And this is how we got the case series and reports. We have got about 74 case reports, ranging from articles ranging right from Cecily Williams' 1933 article to 2021 article. And we have done this, and we found the common themes identified. The foods consumed are always low protein diet, or high carbohydrate diet, or low protein and calorie diet, or there is no milk in the diet, or it's a starchy diet based on potato, or in general it is poor dietary practices. So these are the themes we have identified. Foods consumed are in kwashiorkor. And the themes we identified is delayed supplementary feeding, or early weaning, or breastfeeding only for a few months, the lifestyle changes, or the artificial feeding, and sometimes the diet history is not reliable, so we have ignored that, and of course, maternal nutrition deficiencies. So these are the themes identified in children suffering from kwashiorkor. And in general, for the case series and reports, these are the themes we have identified. One is milk intolerance, and then there's nutritional ignorance, and we have calcium and milk. So people give other foods because there's a calcium and milk allergy, and there's a poor dietary intake and intake of protein deficient diet. And typically the diet is somewhat as vegan diet, because in Western, there is some food fats. So most studies reported in Western diets is because of vegan diet, or they give a rice dream beverage because the rice dream beverage looks like milk, but with no good quality protein. So they give that, and also soy formulas. In cross-section studies, we have identified delayed supplementary feeding, early weaning, again, artificial feeding, shorter duration of breastfeeding, and maternal nutrition deficiency. And typically, again, the diet is low protein and high carbohydrate, or because they have lactose intolerance, they give lactose-free diet. And of course, in general, it is a poor nutritious diet. So these are the themes we have identified. And based on few studies of case control studies, you could see that we have selected only 5 studies. It has to be rigorous. So we have only taken 5 studies. There's not enough. Of course, it's only from PubMed search string. We have not used Embase. We have not used Synanil. We have not used other databases that is typically used because they are all paid. So we use a free database. We'll be slowly updating them. Our meta-analysis is still not published. So you could see that the odds of those who have kwashiorkor, you can see that the odds of not breastfeeding is about 2.4 times. So if you're the children with kwashiorkor have almost 3 times in random effects model that you are not likely to breastfeed. So breast milk has a protective effect on kwashiorkor. So this is the key message we wanted to give effect, and also the role of protein. So otherwise not known previously that kwashiorkor is not due to protein deficiency, though we're trying to debunk the myth that there is a role of protein, especially the nutrition role in kwashiorkor, apart from the antioxidant hypothesis by Dr. Golden. We also have few themes, breast milk substitute, Again, human milk banking, be it fortified or unfortified, and also the bad ones, the impact of digital marketing on formula feeds. We also have some high formula milks, especially for low birth weight infants. What is that? And how many countries are following the International Code of Marketing correctly? So there's a lot of work happening in these areas as well. So with respect to difficulties in breastfeeding, again, the role of vertical transmission of HIV, Down syndrome, we have the Ebola, of course, attention deficit hyperactivity disorder, and of course, postpartum depression, autism, we all have a part of difficulties in breastfeeding. So coming back to the theme of this consultation, national consultation, the breastfeeding in working women. So we have identified 3 systematic reviews specifically focusing on that. One is in the armed forces, and they have themselves identified into 3 thematic areas. The first is, what is your attitude towards breastfeeding? That is the motivation of the mother. And then how are facilities being provided and how are the facilities being used? So the 3 themes, they have come upon some policy in terms of how do we implement, and how is the breastfeeding policy implemented and how it is being evaluated is important. And of course, universal workplace breastfeeding education, especially the taboos associated with breastfeeding in workplaces. How do we address that? And the need for breastfeeding risk assessments and plans based on individual breastfeeding practices and breastfeeding facilities that are available, and what is the access in workplace locations. We have one here right now who is breastfeeding, so we'll have to discuss more in the panel discussion. And what are the exceptions from deployment? Because of the armed forces, usually 5% of all armed forces women take maternal leave every year. So what are the exceptions from deployment and what is the physical fitness testing? So this is one article published by Taylor Hedge. This is from the United Kingdom. We also have what is the breastfeeding after returning to work. This is another systematic review. This study includes 14 studies, almost more than 42,000 women. So in general, the prevalence of breastfeeding after return to work was only 25%. There's a range from 2 to 61%. So you could see how work impacts breastfeeding, and that's the reason why we have this theme. And you can see that stratification by continents and GDP also shows huge heterogeneity. So countries such as Middle East shows the weakest prevalence, especially because of Saudi Arabia is one of the weakest, so it's 10%, and Oceania countries have highest 35%. So when there's a lot of heterogeneity, it means that the policies of those countries have not been proper. So this is the reason why we have such wide heterogeneity. And the prevalence of non-exclusive breastfeeding follows more of a U-shaped curve, which means the highest and the lowest have the highest percentage of breastfeeding. So if you have low, you know obvious that breastfeeding is beneficial. If you have highest, you also know you can sit at home and that you can still breastfeed. It is in between where you're not sure about your own income and you're not sure about the benefits. This is when the suspicions arise and then they start formula. So it is a U-shaped curve. How do you tackle the middle path? When people want to have to go to work for economical reasons, and how do we prevent that? So that is the key aspect of this review. So despite economic status playing a role, there are also cultural aspects. I've told that like Chinese mothers and grandmothers, if they're educated, they're more likely to ask their daughters or the granddaughters to stop the breast milk. So that's how it is. And of course, the length of maternity leave also impacts not only on mental and physical health. So they have 21 studies analyzed. So longer maternity leave leads to more positive mother-child interactions, decreased infant mortality, and longer periods of breastfeeding. So they have recommended that at least a maternity leave of 12 weeks, that is 3 months. In India, we have 6 months, but at least a maternity leave of 12 weeks or more confers the greatest benefits for both mothers and the infant. So this is the new evidence we have. This is by Whitney. And these are the few reviews we were able to read. Some reviews we're not able to access. We also have few reviews on co-parenting. How is breastfeeding and co-parenting important? So there's a systematic review between marital relationship. How is your relationship? And then so there's it's a positive. So there's a positive and moderate level of correlation between marital relationship satisfaction and breastfeeding self-efficacy. So it's important that co-parenting, that the decision be taken together, and also shows that it improves breastfeeding knowledge and breastfeeding attitudes. So these are the key aspects. We have found that this co-parenting intervention significantly improved exclusive breastfeeding at 16 weeks and 6 months of life. So with this, I'll give to AD and he can talk more about policy. Thank you.
Thank you, Dr. Siswan. So there is a saying you must be knowing. Without data, you are just any other person with an opinion, right? So he is obviously not any other person. He is speaking with data, with evidence. So that's why it is important. Okay, so taking it further, I think this is the slide that I was talking about in the quiz. You can see the amount niche. The healthcare cost to India per year will be 875 crore if we don't invest enough in breastfeeding. It's not only that, it will save 1 lakh children's life every year, 11,400 maternal deaths every year. It will prevent 34 million cases of diarrhea and 2.5 million cases of pneumonia every year in India. And the cases of obesity, breast cancer, type 2 diabetes, and ovarian cancer, you can see how much it can reduce. So this is taken from a tool called the cost of inaction tool. It's designed by Alive and Thrive, and the data is extrapolated to the present incidence number in the country. Okay. So this, World Breastfeeding Week, the objective is to do 4 things, informing, anchoring, engaging, and galvanizing. And we are trying to do all the 4 things together, so that we don't, leave any stone unturned to disseminate and to sensitize and to anchor and to talk about it, right? So it's very simple. Now, the effective breastfeeding practices for workplace atmosphere. What are the best practices that every woman and every mother in any formal setting can continue to breastfeed? So these are the best practices. There has to be a policy about maternity entitlement. And okay, so there is one good news before I begin. So you must be knowing that every country has their own maternity benefit, act, their law. It's not that every country will have 6 months of maternity leave. At least in the formal sector, India is lucky to have it. In America, it's not there. Not even 2 months they get a maternity leave. So Save the Children, Bal Raksha Bharat in India, we are supporting 120 countries in the globe. So for the past, 1 year, I was advocating and, writing and doing a lot of work to influence the movement across the 120 countries to have a uniform maternity leave for at least 6 months in all the country, be it Africa, be it Middle East, be it everywhere. Yesterday, we signed that letter and we ratified that as an enactment, as a policy that any employees of Save the Children, even if they are placed in a country which is not complying to the law of the land, if it is not giving that kind of benefit, but the organization will give. So that happened yesterday. So lakhs of employees will be benefiting out of it, even if they are in a country which is not conducive. So that is the first thing, that there has to be a policy enactment. There has to be a provision that each and every employee is sensitive about it. It's not about only giving a maternity leave. After 6 months, how can you sustain? There is a recommendation that you need to continue for 2 years. So even if we are back to office, there has to be some flexi hour. Nowadays, work from home, we manage the entire show for 2 years. Can't we do it by giving an hour of flexibility to a mother? So the sensitivity and the empathy that you need to show, everything cannot be written in the HR policy, but some of the things that we need to ensure as a best practices, providing time and space, then providing options that reduce the separation of the mother from the babies after the maternity leave. Maybe work from home, or maybe an hour of break, or maybe having a creche in the facility, so that they can bring their baby. So these are things we need to do. In India, we are lucky to have so many enactment and provisionings that is actually favoring and promoting continuation and sustenance of breastfeeding in the country. And these are just few names of those enactment and policies. But this is very great to have all these things. But this sad part is how many mothers are into the formal sector. Can you guess the percentage? Out of the total employment or out of the total livelihood options that we have, what percentage is into a formal sector that may have this kind of facility? 3%. It's just 3% of formal employment. 97% are into informal sector, and all this doesn't apply there. So it's a big challenge for us to continue and support this, life-saving interventions in a systematic way. Okay. What are the programs and schemes that are there which talk about the promotion of, breastfeeding? Be it this, little small, celebration that we do every year. But beyond that, there is a full-fledged program. And there are so many programs in Health Ministry and WCD Ministry that emphasize on the importance of breastfeeding, and they reiterate through different kind of messaging and communications to ensure that, right? This IMS Act that I spoke about during the quiz is a very, very stringent penal code. If you violate, you can go to jail as a doctor. You can go for up to 3 years of jail. You can be fined up to 5,000, 6,000, depending on the grievousness of the code. So all these things are there. Now you will not see any formula milk producers. They will be coming with advertisement, putting a baby's image in the packet. So that thing is history now, right? And thank God that there is a vigilant government and a department who is looking into this. This is something we need to understand, that babies will cry. They will have a different sleeping pattern. They will not behave like adult. They will cry for unnecessary things. I mean, you cannot relate anything to that as if this is happening because of lack of breastfeeding. So that kind of misunderstanding we need to throw away from our mind. Even systematic reviews says that it is absolutely normal to have 50% of the healthy infants in the first 3 months to have at least one episode of regurgitation. So if you see there is an episode of regurgitation, vomiting of milk, then you probably think that, okay, it is not digested properly, let's do something else. It is absolutely normal to have 2 hours of crying time in a day, and that has nothing to do with breastfeeding. So this kind of things are absolutely normal. But because we don't normalize and because we don't talk and sensitize in a systematic way, many people will get misled by as if this is a problem of breastfeeding, and that will lead to a self-reported insufficient milk. This is a new term these days, right? Mothers, they feel that I have inadequate milk production or milk because the baby is crying, because this thing is happening. But just to tell you that these are absolutely normal things. So breastfeeding is easier when mother starts learning this during her pregnancy. So can we make a part of the counseling package during the ANC contact point? Baby and mother stay together after birth and in infancy. Can we ensure rooming in and bedding in principle in the hospital? So, you not necessarily need to have a separate cot for the child or the baby, even at home. So in Western countries, they keep it. I don't know, why they're so obsessive about making the child independent from day one. Is very, ridiculous. Then you don't have that opportunity to, feed as and when needed, right? Mother had paid maternity leaves. This, of course, ensure your 6 months of exclusive breastfeeding. And everyone steps up to support breastfeeding. After 6 months, if you are back to office, if employees are supporting you, giving you, flexi time, breaks, then nothing like it, right? And if the mother gets support from the husband and the family member, then it's brilliant. Data shows that a mother who is supported with her breastfeeding by the family member, its chances of maintaining exclusive breastfeeding and to continue for 2 years increase by 2.5 times. It's very, very dramatic, right? Okay, so the first point I spoke, coverage versus the, quality. Don't be happy about your exclusive breastfeeding happened up to 65%. We have just crossed the, SDG target of 50%. You don't know really that is it effective exclusive breastfeeding or what. So try to get there at 90%. Why not 100%? And then also ensure the frequency. So don't compromise the quality for coverage or vice versa. Both things are needed. And I spoke about exclusive, effective exclusive breastfeeding, how important it is. Feeding is a massive caregiving task. We need to understand how many times of feeding are there, per day, suppose average 10 times, right? For a newborn baby. And for 6 months, how many 180 days into times, 1800 times of feeding moment. If you miss once, maybe in a very hot summer weather, your grandmother said ki thoda pani pila do, you just missed once, then you are not doing exclusive breastfeeding. So you have to be correct, you have to be persuasive and persistent for at least 1800 times in the first 6 months. Then only this will happen. So it's a massive task. If somebody is not able to do, just be kind, and it's human to falter. But then there is always a chance to thrive. Nothing has happened. You can always. I have seen pediatrician. I can just take 2-3 minutes of explaining my own personal story with my wife and daughter. There was a problem with initial breastfeeding, but being a national trainer on IYCF, I was like hell-bent, karana hi hai. Hua nahi. ठीक है? Then we called experts from Delhi to fly to Bhubaneswar. They also failed. Didn't happen. It was a very unfortunate case. But then we visited pediatrician after pediatrician. Every day we are changing because, they were not helping. They will talk theory, but it will not translate into action. So there was a clinic. The pediatrician was very busy, and he was the top pediatrician, in the city. And my wife was standing with my baby with a bottle, obviously, because till 3 weeks, the child hasn't started breastfeeding. For a very silly mistake that happened in the OT. For 3 weeks, they didn't allow. So you are, carrying a bottle, right? Then, her, call was there. Then the doctor is inviting, okay, madam, ab aaiye. But वो जो बॉटल है ना उसको डस्टबिन में फेंक के आइए. फर्स्ट थ्रो दैट बॉटल इन द डस्टबिन. आई वाज वेरी सरप्राइज्ड. क्या करें, डॉक्टर कह रहा है, चलो हमने डस्टबिन में डाल दिया. वी हैव नो अदर ऑप्शन. पहले तो बॉटल को डस्टबिन में डाल दिया. देन वी सैट इन फ्रंट ऑफ द डॉक्टर. द डॉक्टर इज वेरी स्मार्ट, वेरी टेक सेवी. ही हैज ए टैबलेट, एप्पल आईफोन. फॉर पास्ट 15 minutes he didn't talk to us anything about क्या हो रहा है, बच्चे का वेट, एंथ्रोपोमेट्री, nothing. He just showed the image of breast cancer one after another. Look, your breast will look like this after 2 days. After 2 months, it will become like this. After 6 months, it will be like this. So we are like, horrified to see all these images. Of course, I understand, what he tries to say, but my wife, not from a medical background, is like panicked. Okay, so ये सब हो जाएगा, ठीक है? So कल से जाके breast feeding करना. मैं तुमको medicine लिख रहा हूँ. How does that help? How does that help? And this was not the first doctor. For all the 3 weeks, different doctors, they played different tricks and techniques to humiliate you, to offend you, but to not help you. So I'm telling this, share. I don't know if it is, allowed to share the personal things, but I'm, out of being emotional, I'm just, telling you that many people need to know the proper techniques of counseling and the lactation management. It is not a simple thing. And that can save a lot of life, right? So that was about some massive caregiving task and how people can be supported out of the way if you know some skills. If you don't know, please teach in the medical college. This is a very human skill you need to impact. There is nothing rocket science. These are simple things, can be taught. It's a transferable skill, right? So many people, they feel constraints by different, socioeconomic, condition. The rich will experience different kind of experience. The poor, the urban, the rural, the tribal, it's very, very different. I spent 6 years in Chhattisgarh, in a Bastar, in a very tribal area. You know how the prelactal feed practice is there? So, it's, everywhere you must be, listening that before even initiating anything, they will touch something very sweet to the baby, like honey or anything else. There are two logic to it. One is the baby will वो आगे बड़े होके मीठा बोलेगा, इसलिए मीठा खिलाते हैं. Number one. Number two, in Chhattisgarh, I found something very weird is that जब तक उसका मामा का मुंह दिखाई नहीं होता है, he cannot start breastfeeding. And if your mama is in Andhra Pradesh, Hyderabad, has to travel by train, it takes 3 days. Till then, they will keep on feeding prelactal, but not breastfeeding. What is this? The other extreme is also seen in Chhattisgarh. You will see the continuation of breastfeeding is till 9 months and 12 months and delayed initiation of complementary feeding. You must have seen the image. जो महिलाएं हैं जो काम करते हैं, खेतीबाड़ी करते हैं, they have a towel and a baby like a kangaroo mother care type, वो always hang to the breast and they do their work. The baby is latching and this continues for 12 months. And children are malnourished because everything has a timing, right? When to start complementary feeding there is a timing. How long exclusive breastfeeding should continue, there is a timing. You cannot play around it. You cannot have extreme of all these things, right? So that was about the fourth point. And the cost of inaction, this tool that I shared, if you I hope that we will be sharing this presentation with everyone so that you have this link, this tool, and you can select different countries. You put India, the entire econometric analysis will be shown to you, and it's a very interesting tool. The trickle down effect we have seen in our programs in Save the Children that wherever there is a distribution of infant milk formula in the name of emergency. In some emergency, if mother has died and due to catastrophic incidents, babies are orphaned, you will opt for wet nursing for some time. If that also doesn't happen, then you distribute. So even in emergency setting, we have seen that the distribution of this infant milk substitute has a trickle down effect by 42%. 42% of lactating mother who can successfully breastfeed will aspire this as a baby milk powder as something aspirational, and it will dilute their breastfeeding. So if ever in future, if you have to do it in a very, very clandestine way for a exclusive, exceptional cases, do it kind of secretively. Don't publicly distribute or just say that you are doing this. So, and that has to again follow some AFAS criteria that we say, it has to be affordable, feasible, sustainable, socially acceptable. If it is tick mark for all the criteria, then only you do. Otherwise, don't do. So there is a huge risk of getting into that zone because it will eventually dilute the breastfeeding practices in the community. And nowadays, thanks to the social media, many people who are looking this as an aspiration of a modern girl and women in the Western country, if you follow them, I guarantee you will dilute your exclusive breastfeeding. They are not the role model to follow in this case. So there is enough literature and science and awareness and sensitization that are there. Thanks to NIN for doing such kind of work and all the medical college and scientific community. Please listen to them and follow their suggestions instead of looking into some social media and other thing to do or experiment. Thank you. So this was all about it. Any questions, I'll be happy to take.
There's a virtual question. Virtually कुछ question है अच्छा. करूँ मैं? कुछ कहाँ से था? नहीं. Any questions from the audience? Question is no questions. Then change my perspective.
Since morning, we have been discussing on this topic, which is so relevant, and a lot of insights from our esteemed speakers. And to take the conversation forward, we have panel discussion, which is on barriers and enablers for breastfeeding among working parents. So are we ready? May I now welcome for the panel discussion, the chairperson, Dr. MVV Murali. He is an esteemed pediatrician with a wealth of experience, a retired professor of pediatrics from Gandhi Medical College and former head of pediatrics at Gandhi Government Medical College in Nizamabad. He served as a senior consultant and D&D faculty at Princess Durusevar Children's Hospital. Notably, he was the past president of NNF Telangana, showcasing her leadership. Thank you, sir, for joining us. We have the moderator of today's session, Ms. Prashanti Vatina. May I request Ms. Prashanti Vatina to join the conversation? Prashanti Vatina is a social scientist and public health professional working in the development sector over 17 years in various capacities and programs, designing, managing leaderships and administration, policy advocacy, partnerships and alliance building, organization development, training and capacities. By academic, she is a postgraduate in community health and nutrition and a certified leadership coach in social sector from ILSS. Welcome, Ms. Vatina. Now, may I welcome the panel members, Dr. Hima Bindu, Dr. Hema Bindu, a dedicated pediatrician at Nilofer Hospital, possesses an MBBS from Osmania Medical College and an MD in pediatrics from Nilofer Osmania Medical College. With a solid academic foundation, she served as an assistant professor at Deccan Medical College for 5 years and currently holds the same position at Nilofer Hospital. Dr. Hema Bindu is a certified trainer in basic NRP, NSSK, SAM, and IYCF and asthma courses, and has conducted very valuable lactation and NRP workshops for the both UG and PG students at Osmania Medical College. May I now call Dr. Suchitra. Dr. Suchitra is an accomplished pediatrician with an MD in pediatrics. She served as an assistant professor at Nilofer Hospital for 7 years, followed by 4 years as an associate professor at Gandhi Medical College Department of Pediatrics. Dr. Suchitra is a distinguished state trainer of trainers for IMNCI, FBNC, CPAP, and a national trainer for NRP. Her affiliations include BPNI membership in 2023. Now, may I call upon Dr. Maimuna Ahmed. Dr. Ahmed, a distinguished obstetrician, completed her education at Grant Medical College, Mumbai, obtaining both her graduation and post-graduation. She further specialized in maternal fetal medicine with a fellowship from the National Board. As a consultant at Fernandez Hospital, she contributes her expertise to maternal care. Dr. Ahmed is a dedicated member of Fernandez Breastfeeding Committee, actively advocating and supporting mothers while educating healthcare professionals about physiological birth and breastfeeding. We have now Dr. Kirti A.S. Dr. Kirti A.S., an accomplished pediatrician. Kirti. Dr. Kirti A.S., an accomplished pediatrician, is the professor and head of pediatrics at SV Medical College, Tirupati. He completed both his UG and PG studies at the same institute. Dr. Kirti has been a driving force as the secretary of IAP, AP State Chapter, and vice president of NNF AP State Chapter. He held the position of secretary for IAP Tirupati branch from 2016 to 2018. We have Dr. Radha, HOD, Gynax, Government Hospital, Mehboob Nagar. She is working there over 5 years, and she is also a master trainer on comprehensive abortion care and other programs. Thank you, ma'am, for joining us. We have Dr. Salima, who is a public health professional working as a health specialist, UNICEF Hyderabad field office since April 2020, and has contributing to the reproductive and child health and COVID-19 interventions for the state of Telangana, Andhra Pradesh, and Karnataka. She also has about a decade's experience of working with Ministry of Health and Family Welfare, Government of India. Thank you, ma'am, for joining us. We also have mother with a 1-year-old child, Savitri. All right, so we will be inviting mothers soon. Thank you, everyone, for joining. Over to you, Ms. Prashanti Batina, to take the conversation further.
Good morning, everyone. At the outset, I would wish to thank the organizers for the opportunity. Coming to N9 is like homecoming. So I worked here for a brief period of 1 year way back in '92. I still have a lot of friends here. And I really love to come here to meet them and participate in scientific deliberations. Whenever I come here, either as a visitor or a SAC member, it is a learning experience. Interacting with the scientists of this prestigious institute of national and international fame is really a privilege. And N9 has helped our department of Gandhi, which is here, she knows. They were having a center in the Gandhi, helping the poor, giving them valuable nutritional advices. A lot of our PGs were associating with NIN for their thesis work. Coming to today's topic, actually, we have been celebrating this breastfeeding week for the last more than nearly 30 years, and since 1992. So still, should we do this? The answer is yes, because still, when you look at the statistics, like just now we have the speakers telling about the NFHS 4 and 5 data. There's a marginal improvement in exclusive breastfeeding rates. And when you look at the early initiation of breastfeeding, which is a very important component, it's a very dismal improvement. There's hardly any improvement. Ulta, there is actually, states like Gujarat, Goa, there is a decrease in the percentages of early initiation of breastfeeding. And all of us know that there's a very important strategy. Just doing this early breastfeeding, that is treating the baby within the golden hour, can reduce in neonatal mortality by nearly 22%. That is the statistics. Still, we have a very high neonatal mortality, national average around 25, as well as NFHS 5. So still there is a need, and rightly, because there's so many issues for the working women regarding breastfeeding, and that is nearly the theme for this year is very oft to help them, to support them, and we have very experienced panelists here. I'm sure they deliberate on these issues and definitely come out with good points to ponder and observe. Follow. Thank you. And I request Prashanti to conduct this.
Thank you, sir. Once again, very good morning to all of you, and for this wonderful panel discussions that's going to happen now. Thanks to each and every panel here for joining with us for this important discussion. As well said by Dr. Vasudev Murali sir, with all his experience, why this is still an important discussion to happen, despite of many years we've been discussing on the same issue, but yet it is continued to be an important discussion to happen. And let's hear to the kind of challenges, the gaps, and some of the interesting experiences that might come from the field that will help the practitioners, the policymakers, and the mothers who are actually facing the challenges on the ground. So I hope that this session will bring up some of the suggestions as well, so that there is something to carry back to all of us. So let me start with maybe Dr. Radha Garu. We have the Honorable Dr. Radha here, working as a gynecologist and obstetrician for the Government Hospital, Mahbub Nagar. Ma'am, we know that there is a huge gap between institutional delivery and the early initiation of breastfeeding that is happening today, which is definitely increasing. There is no decrease as such, we are noticing. So what are the most important challenges that you are observing in the field, and you encounter that, and what do you suggest, how do we overcome that?
Good morning to all. See, the challenges what we are facing. So when our setup in the government hospital, we have now around 45 to 50% of the cesarean sections, and the rest of that is the normal deliveries. And even then, we are facing the challenge by the government giving the midwives who are facilitating early breastfeeding for the normal patients, and also further section patients also we are trying to cope up with, not immediately, even though we are at least in the first hour of the childbirth, we are trying to do the breastfeeding, and around 96% of the first hour feeding we are able to cope up with. That's what we have the statistics.
Right. So also we understand that there is a huge challenges in terms of human resources, the infrastructure that we have. So do you see any challenges that are happening in your observation as well? Or how do you want to address this, despite of having these sort of challenges? How can we overcome taking up the early initiation of breastfeeding?
As you said, there is the challenge regarding HR, human resources. That's why we train each and every person who are in the labor room and also in the OTs and also in the wards. We have medical social workers in the wards. We have midwives in the labor rooms. And also in the theaters, we train the staff nurses there and also house surgeons and everyone, even the PGs there, who are there to take up care of the early breastfeeding. That's how we train each and everyone in order to overcome this human resources shortage.
Okay, so that's where you are also saying that it is increasing now. So you are able to see, you are witnessing that increase of early initiation breastfeeding because of all of these trainings. Yes. Okay, thank you. So maybe my next question to Dr. Maimuna from Fernandez Hospital. Looking at the kind of recent trends of the statistics very clearly talking about the C-section rates or, very higher rather than the normal deliveries, which is directly linking to the reduction of early initiation of breastfeeding. So, how do you maintain, what do you suggest to coordinate between the obstetrician and the pediatricians to happen to bring it an early initiation of breastfeeding? We witness this, usually the coordination in the hospitals kind of, missing, and hence, the early initiation of breastfeeding is delayed a little bit. So what is your experience and what do you suggest on that?
Thank you, Prashanti, for the question. Good afternoon, everyone, and thank you for the opportunity. I think the key to this is shared belief and policy. So if we all, as obstetricians and pediatricians believe that breastfeeding, early initiation and exclusive breastfeeding should be the norm and is what is best, we are already on the same page. Then coming to the hospital policy, working together, having a written uniform hospital policy, then everybody, and training the hospital staff, obstetricians and pediatricians both together, then brings everybody on the same page or pages depending upon how long the policy is. So everybody knows what they have to do. Okay, this is how when the baby is born, this is what is going to happen. Okay, preparing that staff, preparing the mother in the antenatal period, so everybody knows what to expect and what will be the further steps. And when you say increasing number of cesarean section dates, again, that should not be a huge impact as to when we are starting breastfeeding and how we are giving the baby to the mother, ideally speaking. Because the concept of rooming in, which was mentioned by the speaker, that rooming in concept should not start when the mother is shifted to the room. The rooming in should start at the time of delivery, be it a normal delivery or a cesarean section. So having the baby in the room on the mother at the time of normal delivery is obviously easier, with the pediatrician also being in the room, inspecting the baby in the room. But even in the operation theatre, most of the cases of cesarean section, you would have either an elective cesarean section because of various reasons, or an emergency section because of non-progressive labor, or any other non-emergent, not a category 1 cesarean section, where the baby is not expected to be that sick when the baby is born. And even the mom is not expected to be that sick. And they would mostly be under regional anesthesia. So in that case, having the baby resuscitated or checked in the operation theatre itself, having the pediatrician in the theatre itself, mom can see the baby, okay, mom is distracted with the baby, easier for us to perform, immediate checking the baby, cleaning the baby, drying the baby, wrapping the baby, and bringing the baby on the breast, getting the oxytocin reflex, helps us also in our reduction of PPH. So there are challenges, but the more we look at challenges in the term of problems, the less we can do something about it. And look at challenges in the term of coming up with solutions and having a criteria of breastfeeding only, no separation of mother and baby, then we work out the solutions.
It's to be very easy. I know that it's not very, we all know that it's not very easy to put it in practice, but yet it is a practical solution you have given to some extent. If we start practicing it constantly and continuously with mind and soul that we wanted to initiate this, then I think it's easy to make it possible. Well said, Dr. Maimuna. Let me go on to my right, to Dr. Umedi. The question to you, sir. If we observe the statistics of NFHS 4 and 5, there is a decent improvement, at least, if not to a larger extent, at least there is a little improvement in terms of exclusive breastfeeding practices, both at state UTs and nationally. It's been mentioned as 54.9 to 63.7% of it is visible now. What are the opportunities you see in the recent past which has contributed in improvement of this exclusive breastfeeding?
Thank you, Prashanti. I'd also like to thank the organizer for giving me the opportunity. Well, it is a good sign actually, because it is a positive sign, because maybe if so much of propaganda on the breastfeeding in various media and all that, but at the same time, post-COVID and post-COVID may be helping that, because mother is residing at the home and giving, and I'm working in home. Work from home also is a contributor for this factor, and also the education, the healthcare workers, they approach to the mothers about regarding the breastfeeding, benefits of breastfeeding. They are telling more on, maybe they are educating many mothers, and at the same time, I have to be very cautious about the first hour initiation of the breast is very important. But even though the breastfeeding is increasing, as you said, but at the same time, where alarming sign is initiation of breastfeeding within 1 hour, it is not improving. That's very alarming situation. We have to concentrate more on that. Why that happens, I don't know, because maybe they fall from our healthcare professionals, maybe the obstetricians, maybe the pediatricians, maybe the nurses, midwiferys, and all that. But we have to concentrate on more than. But that's why the government now, either in Telangana and Andhra Pradesh, they're introducing midwifery in assistants in the labor room as well as in the OT theaters, operation theaters itself. They're practicing keeping the baby for 1 hour on the mother's abdomen and initiating breastfeeding within 1 hour. Definitely next National Health Family Health Scheme, definitely that percentage will rise. So thanks to the all the midwiferys, we have to thank the midwiferys.
So, as a leading question, one more question of the similar lines, Doctor. In your opinion, what are the kind of challenges in further improvement of this exclusive breastfeeding? Also, you have half answered this already now, but maybe if you could strengthen a little more on the same point, please.
So, one more thing we have to think that this IMS Act, though it is the Act is very, very powerful, very this thing. So many in all over the universe, they're praising our Act, IMS Act, but on action, so nobody is penalized for doing practices of malpractice. But that means subscribing the infant substitutes, milk substitutes, but nobody is getting penalized. I don't find any this thing nowadays. So another alarming thing is the production of milk powder. So previously it was 29,000 tons. Now it is increased to 31,500. So quite alarming. Even the IMS Act is there. We are practicing. Every year we are celebrating breastfeeding promotion week. Still, the production, the market, the production is increasing. So where is where it is? So we have to concentrate on that. So it should not. On paper we are seeing so many things. On paper, breastfeeding is increasing. On paper, IMS Act is very much available. On paper, everybody is telling that I am giving breastfeeding, but still only 64% exclusive breastfeeding in the observed in the mothers. So it is not the forcing of the law, but it should come from heart. So every mother should see that I have to give my milk only to my mother, my baby. So one saying the breast, they mean animal milk for their calves, mother milk for the baby. And while animals again is going to give their breast milk for their offsprings, why not human beings? In humans, we are having a lot of options. So if my milk is not there, the substitute is there. So that's why in that way the mother will be. Suppose if mother says there is no alternate for if without my milk my baby will not survive. If that concept occurs in her mind, definitely the lactation failure will never occur at any times. So these are the challenges, and also our workplace and also because education is increasing, at the same time the mothers are also working. The breadwinner now, not only the lactation, but breadwinners over the family of the mother. So mothers has to work for the breadwinning. So that's why. So the companies now they insisting in the implementation of 6 months maternal leave is confined to only government institutions. Strictly they are following, because the paid leave is given only in government institution, not in the private sector. But the Amendment Act says in 2017, the maternity leave must for either it's a private or government, they have to give. But it is not implementing in the private sector. At the same time, and we have to, and recently the government of Andhra Pradesh, they issued a circular that whether it is government or private, whether it is hospital or any offices, there must be breastfeeding corner. So that to improve, to just at least just some initiation to improve the breastfeeding. So, and at the same time, workplace flexibility of the working hours for the lactating mother, and we have to respect the lactating mother always. And though if you compare suppose the company may think that the lactating mother, because of lactating mother, the productivity is decreases, but it's not true. There is one study in the US that told that if you spend $1 on breastfeeding practices or anything, spend $1, you will get in return $35 in return. So in that way also it is so 1:35. So in that way also we can explain to the society the importance of the breastfeeding and all this. Thank you.
Thank you, Dr. Kiriti. I think that was very clear on at least on 3 important points you have stressed. One definitely on the awareness have to continue, or even in fact it has to increase for the mothers or the parents to understand the importance of breastfeeding so that they practice it meticulously. And 2, I understand despite of many policies that has come up, but still there is gaps in practicing it. Maybe the laws or the acts that has to be taken it in a very serious note, if not practiced properly. Penalization is one point you were mentioning. And third, the private practitioners, especially the private institutes, have to bring in a breastfeeding corner so that there is of course, also the 6 months, paid leaves for the working mother, so that there is an increased, mothers practicing the breastfeeding. I think those are very valid points. So hope that happens into practice sooner in our country. At least let's hope that. And of course, that won't we have to face that. My next question to Dr. Suchitra Garu, Associate Professor from Gandhi Medical College. Considering the fact that approximately 89% of the deliveries are today happening in the institution, but the fact remains is only 42% of the newborns are breastfed within 1 month. It is similar in both the NFHS studies, and is kind of a stagnant despite of many initiatives like, it's World Breastfeeding Week or the Ma or Poshan Abhiyan. So many things we have brought in, but yet, in the practice, we still see the same scenario. So, what more should be done from the policy level to improve and sustain optimal breastfeeding, especially for working mothers?
Thank you, Prashanti, for the question. At the outset, I thank the scientific persons for calling me and inviting me here. It's year after year that I'm here for the Breastfeeding Week. There's something that is changing that we are looking at towards the society. Yes, there is a policy maker. Policymakers put in a lot of effort collecting the data, like what Dr. Srishwan was showing to us and sharing with us all the things that happened from past 30 years. And right now we are still holding back and conducting the program, and still we are lacking and trying to bridge up the gaps. So where is the thing that is lying? All that is there is in the mind. All that I have to say is it in the mindset. See, we always tend to follow these practices. We have the policies, be it a mom or be it as a Ma program. These programs are well designed and scientifically well made, and coming to the extent of its being spread to the society, or where the knowledge exactly has to be spread, or where the program exactly has to be taken. It has to be seen that the same steps, like stringent action to be taken. See, we heard from Dr. from Jipma in the morning talk saying that it is not enough that it is not the portion of the doctors or the nurses to take care about the breastfeeding. It's a God's natural gift. And we have to owe to the thing that any person, birth companion, have to be trained initially. Olden days, we have seen in the golden era, we have to call that as, the mothers were never trained, we never had programs, but then they had doing this exclusive breastfeeding. But over the ages, as we are advancing, as the technology improves, why are we lacking and where are we lacking? So when we have these policies that have been developed or the things that are coming into existence, seeing to the West, we feel that breastfeeding was more in the East rather than the West. The data also shows that. It may be due to many reasons. And of late, because of this cancer, breast cancer or other social enigmas, now they also started to have breastfeeding. So why we have, what is the system failure here? System is like making the laws is good, the laws are in their place, and even the programs are in their place. But when it comes to implementation, where are we? So when we have to give the data, that the data is saying that 90% are institutional deliveries. But why is this 90% not having the 100% of the effective or initial 1 hour breastfeeding? See, there is a lot of gap and gaps are there. We insist that the deliveries, whichever are conducted, there should be a birth companion. Is it possible practically? Be it a private or be it a government sector. Both areas we are finding difficulties. Yes, we can talk a lot. We can have a long lectures on this. But only thing is implementation is a problem. The mindset has to change. Be it any person available at that point of time. It need not be a pediatrician all the time. It need not be a gynecologist all the time. It need not be a nurse all the time. Even the attender. So whenever the antenatal checkups were done, there is a birth companion to be insisted on. It may be a husband itself. So the male, usually in this male-dominated society, what we have to call, still we are in that. We have to accept it. Where a mother is not, once the woman is pregnant, it is towards her family. Like she will be shifted to her home place where she feels comfortable. That is what is the intent of sending her to the home place. But at the same time, she needs the support of the husband also. So this theme this year, what we are going is to have both of them to be together, to encourage, to support each other. And this will enhance even her breastfeeding. So what neuroendocrine reflex we talk scientifically also will work out when both are together. And the other important thing is the women need to be supported not only nutritionally, psychologically, mentally, and financially. So the policies are also like 6-month paid leaves that we have to deliberately go ahead and be it a public or private sector, they should be paid and it should not be a burden onto the family. Above that, see to the prices what they have mentioned. Sir has just now mentioned that $1 may give $35. Now US is sitting back, global initiative call has come up when WHO is saying that spending $4 per this breastfeeding will cut down thousands of crores. So we are not seeing it in immediate act. Why the policy has taken longer time is we don't expect the results immediately. If you breastfeed now, it takes a child for the next couple of years. It's to his youth. Till then only we can see the productivity and economy and the GDP of the country increasing. So we cut down on the infection rate, we cut down on the cancer rate, we cut down on the educational status. So all this will be based on the simple fact of breastfeeding. Initiation of breastfeeding is mandated. So why this first hour has come, last couple of years, we are much more pondering on this early initiation. So why early initiation is, once it starts early, it sustains. If it doesn't start early, it takes a longer time. So this fact has to be clearly emphasized to the mother. Once they decided to have a family, from that time, this talk. Usually only at the delivery room or only at the point where these people are in contact, like the period where the breastfeeding comes into picture is only after delivery. So this talk has to be started even before that. Even before the woman is planning for a pregnancy, she has to know about the benefits of it and how she has to get a support. So with all these things, the policies, whatever have been happening till now, whatever the government policies are there, they have to be rechecked or rethought about. And we have to have a training program. We have many training programs on this. Once the training program gets finished, things have to be percolated in the society. And we have to see and recheck our things. So whether they're happening district-wise, it has to be going through each and every local areas and make the local groups and be communicating with them back. The feedback is not the thing. The main is the feedback that we are not getting. So now, even last year, we have started in Telangana district also. Districts of Telangana, we have started of having these groups, like every district, there are a couple of healthcare workers along with the pediatricians around, and also the BPNI team also coming into picture and seeing that they have started to go ahead with this initiation of the breastfeeding. So we are now giving the hospitals, like last year we have got 11 hospitals which have been designated that the early initiation of breastfeeding has happened. So we want to increase it to the other sectors also, not only those 11 hospitals. There are so many public sector, government hospitals and government centers where it has to still take up into. So all these policies that have been happening, there is always a gap. To fill the gap, we need to get into the picture. Thank you.
As an extension, ma'am, are we also taking this to the private hospitals, or is it only starting with the government hospitals?
We started off with the government. The BPNI has taken with the government, and now the certification is with the private also. Last year, that is now yesterday's data, is 34 hospitals totally. Out of that, only 4 are the private and remaining all are the government sectors. So it is all about the commitment. They just come over to the center. They have a written format of yours, of the policy. The BFHI policy is there, whether they are following the policy. Any milk substitutes are being displayed around, or if they are using anything. There are conditions where we have to use, but it is not for all. There is a very minute percentage, and it should not be labeled at the same time. So that is one thing we have to consider. Wherein there are some situations where mother expired or she's terminally ill where she cannot provide. Milk banks are the other things that have come up. So that also have to be taken into account. Thank you.
Thank you, ma'am, for stressing again on how important it is to be, getting the policies largely into the implementation. Otherwise, all these policies becomes on the paper base, but in the practice, it will be not taking place. So also on the importance of mothers to be educated. So I think I see those 2 important points. The partners on board, not just educating mothers now. So thank you for that piece of information. I know we are supposed to have a working mother today. working mother. So she is a mother, but yeah. So I have, we have Dr. Salima here. So maybe that working mother's question can go to Dr. Salima, not because of the working mother, but because of the information or the piece that you collectively collect from the communities on behalf of that. I just have one question to you, Dr. Salima. So, being a working mother, it is certainly a challenge to continue the breastfeeding, exclusive breastfeeding to that matter. So what you hear from the community, how difficult it is to continue the exclusive breastfeeding? What are the different challenges the mothers raise from the community? If you could share certain inputs that you collectively gather from the community.
Thank you, thank you. So before I launch into the, what I hear from the community, let me tell you a little bit about how we are engaging with the communities so that it gives you a perspective of how the information is collected. So to begin with, along with the WCT department, there are some videos that have been developed. These are called the Alna Palna videos. And these Alna Palna videos, they are a set of 30 videos, which are age specific starting from the first trimester of pregnancy right up to 24 months. So they are targeted towards the pregnant woman or towards the working mother or the actual mother who's in the community. And these videos are delivered through 2 to 3 channels. One, through the Anganwadi workers who are actually in the community. And we have trained the Anganwadi workers on how do you deal and interact with the community. So it's interesting, the videos look at what you should be doing, how you should be doing it, and why you should be doing it. For example, it looks at the entire nurturing care framework. So I'm going to give you an example about nursing rhymes. Why do you have to look at songs? Why do you sing songs to the child? You are supposed to sing songs to the child. When you do it, when the child is bathing, when you're trying to put the child to sleep. Why you have to do it? Because you have to ensure overall development of the child. You have to ensure that the child learns imitation and a lot of other things. So it's about systematically giving information to the mothers. And this information is delivered in 2 ways. One is either the Anganwadi workers call the mothers who are in that age group, like, say first trimester pregnant women or second trimester pregnant women, or the young, just delivered mothers, they are called and they are delivered these messages in a group. The other way of doing it is that when they go for home visits, they use these messages to again, play the video, then you stop the video, there are certain questions, you interact with the mother with the help of those questions, and then you take things forward. So it is not about just delivering the videos. It is about that interactive mode that really comes into play. So that's the background intervention that is being looked at. Now you understand that these interventions are in the rural areas of Telangana. So the kind of difficulties that we get are largely about women who are migrant workers, who do not have, who have to themselves go out to work, or they do not have the time because they have a lot of household work. So the pressures that they are going through are largely because of the fact that they themselves have so much of, work onto their plate, or because they have to go out and work and earn. And they do not have family members. A lot of people have very clearly pointed out that, there are no family members. The caregiving is left to the mother. So there has been an attempt to involve family members into the videos. We've had father involvement, we've had caregiver involvement, but honestly, it's limited given the kind of, settings that we are working in. So that's the background. And those were the facts that A, they do not understand the importance. B, even if they understand the importance, they are not aware of, they do not have the time to actually deal with it, which is why the whole idea of when do you do it? You do it when you're, when you're doing other routine things. How do you incorporate it into the system? And 3, of course, because nobody has told them about it, or because, some doctor has prescribed,
the supplements and other things. So that's why I think these are 2 or 3 important things that come up during our introductions. And I would like to come back after I hear from her. I would like to come back to you with some more thoughts around what's been happening in Telangana, which are policy level and systematic level interventions, health system level interventions. Thank you.
Thanks, Dr. Salima.
Yeah, 1 minute just before she answers. So, well said that you are talking about the working mothers, and the biggest gap that we are seeing here is like working mothers. When we say working mothers, it's not only those working in institutes, working in some companies, working in some schools and colleges or hospitals. It is the working starts with every place, be it a homemaker to any other. So that is where she wants the working mother right now who is sitting in front of us. She is not a working woman of educational status, but definitely we have to listen, and there is a lot of gap when we have to decide to those areas to that which she is talking about. So this sector we will hear, and then we will ask about what else is happening in the other sector. Thank you.
Thank you, ma'am. Well said. I think working mother ka definition should be probably changed, redefined, and then even if a mother is at home, but doesn't mean that it's not a working mother. So in fact, full work for the mother at home as well. I think it has to be redefined when we are using these terminologies hereafter. Thanks for that. I think the first doctor from Jigpar also has stressed on the same lines. I hear that. So, Ma Savitri, thank you so much. Meeru anta dooram ma kosam ikkadiki vachi maaku time ketayichinanduku mee pillartoti maaku first of all meeru exclusive breastfeeding ante పూర్తిగా తల్లిపాలే ఇచ్చారా ఎలా మీ తల్లిపాల ప్రాక్టీస్ జరిగింది అంటే మనం బ్రీఫ్ చేయగలరా సావిత్రి?
మా ఇంట్లో మమ్మీ వాళ్ళ
మీ చైల్డ్ ఏజ్ ఎంత అమ్మా?
నాకు 20 years.
బేబీ బాబుకి ఇప్పుడు 1 year. 1 year ఇప్పుడు మీరు ఎప్పటి నుంచి తల్లిపాలు ఇవ్వడం మొదలు పెట్టారు?
పుట్టిన 1 hour నుంచి
1 hour నుంచే ఇచ్చారా? గుర్తుందా మీకు? హాస్పిటల్లో డెలివరీ అయ్యారా?
హాస్పిటల్.
ఓకే. సో ఎందుకు మీకు 1 గంటలోనే తల్లిపాలు ఇవ్వాలని అనిపించింది?
నార్మల్ డెలివరీ అయినాక మా మమ్మీ కానీ మా అత్త కానీ 30 minutes కే ఇవ్వాలి పాలు మంచిది అని చెప్పేవాళ్ళు. అట్లా డాక్టర్స్ అడిగి 1 hour లోపే పాలు ఇచ్చేది.
సో మీ ఇంట్లో వాళ్ళకి అవగాహన ఉంది, 1 గంట లోపలే తల్లిపాలు ఇవ్వాలి అన్న అవగాహన మీ ఇంట్లో వాళ్ళకి ఉంది, మీకు డాక్టర్ కూడా చెప్పారు, అందుకని మీరు స్టార్ట్ చేశారు. దాని తర్వాత మీరు ఎన్ని దినాలు అట్లా 1 తల్లిపాలు మాత్రమే ఇచ్చి పెంచారు, వేరే ఏ ఫుడ్ ఇవ్వకుండా?
కంప్లీట్ 6 months కంప్లీట్ అయిన వరకు తల్లిపాలే. 6 months కంప్లీట్ అయి 7 వాటప్పుడు మంచినీళ్ళు, సర్లక్, ఆపిల్ ఉడకబెట్టి అలాంటివి అంగన్వాడీ నుంచి.
7th month వరకు మీరు మంచినీళ్ళు కూడా ఇవ్వలేదా? తేనె ఇవన్నీ మనకు ప్రాక్టీస్ ఉంటది కదా జనరల్ గా పెట్టడము, అది కూడా ఇవ్వలేదా?
తేనె అవన్నీ వాడడం మా ఇంట్లో వాళ్ళకి
వారి ఇంట్లో వాళ్ళకి నచ్చలేదని ఇవ్వలేదు. చాలా మంచి విషయం చెప్పారమ్మా మీరు. ఇది చాలా అరుదుగా జరుగుతుంది, అంటే చాలా తక్కువ మంది ఇలా ప్రాక్టీస్ చేసే విషయాన్ని మీరు మాకు షేర్ చేశారు. ఈ ప్రోత్సాహం మీ ఇంట్లో వాళ్ళు లేకపోతే జరిగేదా?
మా హస్బెండ్ నాకు సపోర్ట్ చేస్తారు.
ఓకే. He was here. I think the child was feeling uncomfortable. We went out to take care of the child. Yes.
You also have to analyze teachers.
Okay. మీరేమన్నా తల్లులకి షేర్ చేయాలనుకుంటున్నారా మీ తరపు నుంచి? అంటే యూజువల్ గా ఇది చాలా కష్టమైన పని, 6 నెలల వరకు ఒట్టి తల్లిపాలు ఇవ్వడము, వేరే ఏమి పెట్టకూడదు. ఎందుకంటే యూజువల్ గా ఇళ్లలో మనకు ఎట్లా ఉంటుందంటే అది ఏదో ఒక ఫుడ్, తేనె లాంటివి కానివ్వండి లేదా మంచినీళ్ళు కానివ్వండి, ఇవన్నీ తాగిపించడం చాలా అలవాటుగా ఉంటుంది. సో వీటన్నిటిని మీరు ఎట్లా దాటుకొని అలా చక్కగా 6 నెలల వరకు మంచిగా బ్రెస్ట్ ఫీడింగ్ ఇస్తూ దాని తర్వాత ఫుడ్ స్టార్ట్ చేయడం, ఇవన్నీ ఎలా ప్రాక్టీస్ చేయగలిగారు? మీ నుంచి ఏదైనా సమాజానికి ఒక మెసేజ్ ఇవ్వాలనుకుంటున్నారా?
ఇంట్లో మనం చేసుకునే ఫుడ్ బట్టి మన పాలు ఎంత వస్తాయి అనేది చెప్పొచ్చు. రాగి సంకటి, జొన్న రొట్టె అలాంటివి మా ఇంట్లో ఎక్కువ పెడతారు కాబట్టి 6 months వరకు నాకు పాలకు బదులు ఏదైనా మా వాడికి పెట్టలేదు, పాలే సరిపడేది.
సరిపడా పాలు మీకు వచ్చింది. అది కాకుండా మీకు ఇంట్లో వాళ్ళ ప్రోత్సాహం కూడా ఉంది. థ్యాంక్ యూ సో మచ్ సావిత్రి, మీరు ఇంత దూరం మా కోసం వచ్చి చాలా ఇంపార్టెంట్ మెసేజ్ మాకు షేర్ చేసినందుకు. The teachers sitting next to you, మేడం మీ ఎక్స్పీరియన్సెస్ ఏమన్నా చెప్తారా కమ్యూనిటీ నుంచి? వర్కింగ్ మదర్స్, ఇప్పుడు తను ఇంట్లో ఉన్న మదర్ గా తను చేసుకోగలిగారు, అలాగే కొంతమంది మీరు వర్కింగ్ మదర్స్ ని మీరు ఎక్స్పీరియన్స్ చేస్తూ ఉండొచ్చు కమ్యూనిటీలో. వాళ్ళు ఎటువంటి ప్రాక్టీసెస్ లో ఉన్నారు, వాళ్ళు ఏం చేస్తే బాగుంటుంది, గ్యాప్స్ ఎక్కడ ఉంది, అది ఏమన్నా మీరు చెప్పగలరా?
వాళ్ళు వస్తారు, మా సెంటర్కి వచ్చి మీటింగ్ పెడతాం. మీటింగ్ పెట్టి వాళ్ళకి చెప్తాం, పుట్టగానే తల్లి పాలు గవర్నమెంట్ హాస్పిటల్ నుండి డెలివరీ కావాలి, వేరే ఇవ్వడం వలన పిల్లలకు వ్యాధులకు గురవుతారు, ఇలాంటి విషయాలు చెప్తాను. చాలా మందికి ఫాలో అవుతున్నారు.
ఓకే, ఎలాంటి వ్యక్తులు ఫాలో అవ్వలేకపోతున్నారమ్మా మీ అబ్జర్వేషన్ లో? ఎవరికి ఇలా ఇబ్బందిగా ఉంటుంది ఇలాంటి ఫాలో అవ్వడానికి?
కొంతమంది ఆపరేషన్ అయిన వాళ్ళు ఇవ్వలేకపోతున్నారు అని చెప్పేసి.
ఆపరేషన్ అయిన వాళ్ళు ఇంకెవరినన్నా గమనించారా మీరు ఇలాంటి ఫాలో చేయలేకపోతున్న వాళ్ళు?
కొంతమంది పెద్దవాళ్ళు ఓన్లీ లేదు మేము అప్పటి నుండి ఇట్లాగే ఉన్నాం అట్లా కూడా కొంతమంది ఉన్నారు, కానీ చాలా మటుకు కొంతమంది కావాలి.
ఓకే, సో రెండు విషయాలు మనకు, ఒకటి ఆపరేషన్ అయితే తల్లిపాలని ఇమీడియట్ గా స్టార్ట్ చేయడం కష్టం అవుతుందని తెలుస్తోంది. రెండోది పెద్దవాళ్ళ ప్రోత్సాహన లేదా పెద్దవాళ్ళకు ఉన్న రాంగ్ ప్రాక్టీసెస్ ని మనకు ఇప్పటి తల్లులకి ఇవ్వడం వల్ల కూడా రాంగ్ ప్రాక్టీసెస్ స్టార్ట్ అవుతున్నాయని చెప్తున్నారు మీరు. ఇంకేదైనా ఉందామా షేర్ చేసుకోవడానికి?
వర్కింగ్ మదర్స్ చాలా ఇబ్బంది పడుతుంది మేడం. వర్కింగ్ మదర్స్ ఏమంటారంటే జాబ్కి వెళ్తాం కదా, మాకు తల్లిపాలు ఎలా ఇవ్వగలుగుతాం, గవర్నమెంట్ లో అంటే వాళ్ళు ఇస్తున్నారు 6 months లీవ్, కానీ ప్రైవేట్ లో మాకు ఇవ్వదు కదా అని కొంచెం ప్రాబ్లమ్స్ చేస్తున్నాం మేడం.
So I think it's a very clear message that if it is non-government employee, then it will be difficult for them to practice this exclusive breastfeeding being at home, because for them economy is important or income is important and they have to go to the work.
హాస్పిటల్ కూడా చాలా మంది 1 hour బ్రెస్ట్ ఫీడింగ్ ఇవ్వట్లేదు మేడం, చాలా వరకు చూసాను నేను. ఎందుకంటే వాళ్ళు ఏమంటారంటే మీకు ఏం తెలుస్తామా, మాకు తెలియనంత తెలుసా మీకు అని తల్లిదండ్రులు అయితే తెలుస్తున్నారు, మమ్మల్ని కూడా అడుగుతూ చెప్తున్నారు. అలాగే మేము చెప్తున్నాం కూడా 1 hour కంపల్సరీ బ్రెస్ట్ ఫీడింగ్ ఇవ్వాలి అని. అలా కూడా చాలా మిస్ అయిపోతుంది.
హాస్పిటల్ స్టాఫ్ మీద అంటున్నారా లేకపోతే పేరెంట్స్ మీద? స్టాఫ్. So staff trainings will need to be
implementation of the trainings that are already planned or made forward.
మేము అదర్స్ ఎందుకు చెప్తాం మేడం, మీరు వెళ్ళినప్పుడు మీ అత్తగారిని మీ అమ్మగారిని తీసుకెళ్తారు కదా, ఖచ్చితంగా ఇమ్మని చెప్పండి అంటే వాళ్ళు మంచి మాకు చెప్తారు. మళ్ళీ డాక్టర్తో మాట్లాడాను, సిజరీన్ ఏం కదా ఎట్లా ఇస్తారు మా పాలు వాళ్ళు అని చెప్పాను.
So the strong beliefs probably is overtaking the scientific or evidence-based education as well. So despite the trainings have been provided for multiple times, but still in getting into the practice or tuning their mindsets, as you mentioned, I think it's important because they are also mothers or ex-mothers or grandparents, practiced some wrong practices still continuing and imposed on the current mothers maybe. So that's a valid point. I think we need to take it like, how do we monitor the practices at the field level? So we probably are good at or past the training implementations, but the points to be taken is the monitoring mechanisms. You know, how the knowledge is being getting into the practice right now. Thank you so much, Amma. So I think my question here back to the panel from Dr. Himabindu Garu from Nilafur Hospital. I think we heard a lot of good discussions around C-section, institutional delivery, how do we bring it early initiation of breastfeeding. Also partial discussions or good discussions happened on the policy changes that has happened. So just to reiterate on the same lines of, how far this, we discussed a little bit touch base on the express breast milk till time. So how far this express breast milk can support the working mothers in continuing this exclusive breastfeeding? Do you hear this in the practice in your field, or what kind of advice you will give to those who wants to try this out, madam?
Thank you for the question. Good afternoon, everyone.
regarding express breast milk. The guidance for working mothers should begin before delivery itself, during the antenatal period, and even during her maternity leave period, the mother has to be guided about what to do after she returns to work. Even she has to be supported even after returning to work. So before delivery, as we have noted, antenatally, mother has to be counseled about importance of breastfeeding. And there are also apps like I Decide app, which can help these mothers. And at the time of delivery, important factor is initiation of breastfeeding within 1 hour, along with kangaroo mother care, through quality initiatives like Lakshya and bonding agents, as Sir had told in the morning. So these will help in initiation of breastfeeding in the first hour of life, and this will help in further continuation of breastfeeding in further months. And before returning to work itself, mother has to be taught about expression of breast milk. Initially, first she has to be taught with hand expression of breast milk. Every mother has to know this technique. Then followed by use of breast pumps, if they have. Then once she returns to the workplace, she has to be provided dedicated time and place at the workplace for expression of breast milk. And every time she has to wash her hands with soap and water before expression. And early in the morning, before she leaves for work, the mother can give a feed to the baby. And with the other breast, she can start expressing milk on the other side. And initially, even though she may not get enough milk, at first, it may be necessary to express every 3 to 4 hourly to maintain milk supply. But later on, with practice and good expression, she will be able to empty her breast with a pump in 10 to 15 minutes itself. And when she is at work also, she can try expressing as often as during tea breaks or during lunchtime, or whenever she feels that fullness. This will help in preventing engorgement and maintain supply. Because engorgement, it will build up the inhibitory factors, and again, it will hinder breastfeeding. And mother should be provided a quiet and relaxed environment in the workplace. This will encourage milk ejection or letdown reflex. And she can think, it will be very helpful if she thinks of her baby at the time of expression, or look at his picture, or she can bring a clothing item from the baby to work to encourage milk letdown. And in addition to all this, mother, she should take proper nutrition and plenty of fluids. She should never ignore her thirst, and she must take adequate rest and sleep at night. And she must have night feeds, at least 2 night feeds, because this will encourage a prolactin reflex and more milk production. And along with this, she should have a breastfeeding friendly family atmosphere along with work atmosphere. Her family should help her with household chores. There is nothing wrong in giving work to other family members. She has to help. They have to help her in this household work. And there are different methods to express breast milk, like hand expression. Everyone, we should tell her the technique. I don't have the videos right now, but they are available online. And breast pumps, like manual breast pumps or battery operated or electric breast pumps. And regarding storage of breast milk, this breast milk can be stored in storage bags which are disposable, or we can use clean food grade containers. They should be BPA free, or simple steel containers they can be used. And this milk can be stored at room temperature for about 6 hours. At the workplace, if storage facilities are not available, then she can use this insulated cooler bags with frozen ice packs can be used. They can be used even while traveling also. Or in the fridge, they can be placed for 24 hours. Suppose if they don't intend to use or excess milk is produced, they can store in the deep freezer for about 3 to 6 months. 3 months for unpasteurized or pasteurized for 6 months.
And before freezing, they have to leave 1 inch above the container because breast milk will expand on freezing. And for thawing, they have to bring it to the room temperature before using. So they can place it overnight in the refrigerator or they can place it in lukewarm water. And they should never thaw or reheat it in the microwave because it will destroy the nutrients or it will reheat unevenly. And once thawed, the milk has to be used within 2 hours. And because the fat collection globules will be there, they can gently swirl the milk without vigorous shaking. And cleaning the pump and all, either manual or electric, they have to clean it with in a clean basin in the sink. Directly, they should not throw it in the sink. And they have to wash it with soap and water. After that, further, if they want, they can boil for 5 minutes and air dry. And with careful planning and forethought, proper expression of milk, they can continue breastfeeding even after 6 months for 2 years and beyond also.
Good learning, Smart. Thank you so much. It's a difficult process though, but if the mother wants to, is determined to go with breastfeeding, I think nothing can stop her. So I think if she can follow all of this, or the family is supporting, or the workplace is supporting them to do this expressing the breast milk, I think it's going to bring in a good change for the mothers who are working, but yet they are determined to go for the breastfeeding. Thank you so much for that information, ma'am. Maybe I think we are running out of time, but I think if I'm allowed for last 2 more questions to go in. Dr. Suchitra, Salima, we have stopped in between discussing on the kind of initiations or the policy decision makings that's happening at the national level or at the state level. Since you take care of the 3 states, maybe if you could brief us, what are the good initiatives that's going to happen to still promote this early initiation of breastfeeding?
Thank you. And I'm glad that you gave me this opportunity again. I think because I'm coming back to the fact that you said what next, and I want to start from there. What next? See, first of all, I think we need a mapping of all the good interventions that are taking place by different states. Let me begin by what we heard from our colleagues in Telangana today. The first is about the PHFI accreditation, the Breastfeeding Friendly Hospital Initiative. It's a very systematic accreditation of how you go about it. You were speaking about how everybody speaks the same language and everybody has to, come together. I think this accreditation is a way of making sure that the entire facility speaks the same language. And it looks at those 10 steps of breastfeeding. I think Nilofer had a very important role in promoting this. Other hospitals have also taken it forward. But also to bring to a point here that it's not only the hospitals that have really taken this forward and the government that has taken this forward. And I bring this point here because we have 2 important champions here from NNF and IIP on this dais itself. It was IIP TCP also joined hands to promote the accreditation, and they committed for this in front of Dr. Sumita Ghosh, the then Deputy Commissioner for Child Health last year in Telangana. So I think the role of professional associations in promoting these activities, be it FOXI, be it NNF, be it IIP, I think that's a very important role, and we should not ignore that role or say less on that role. Second important thing is we have a program on early childhood development that we are implementing in Telangana again. And one important learning that program brings is that joint trainings of frontline workers. So when you look at the joint training of Anganwadi workers, ASHAs, as well as their supervisors and probably some Panchayati Raj representatives, it is this joint training that brings in further impact because all of them are on the same page. So that's another learning that we bring to the table. The third thing is from Andhra Pradesh, and that is the Care Companion program that Dr. Kiriti, you have been leading. And the Care Companion program looks at a very specific set of individuals, and that is the mothers who have been admitted in the postnatal wards.
We are speaking about the antenatal wards, and that's a very difficult time to catch mothers. Of course, there is very systematic counseling even happening at that point. But when she's in the PNC ward, she's very receptive to whatever the medical officer or the nurse really wants to say. How can we as medical professionals capitalize on the fact that she is there with us for those 3 days or those 7 days? And that's when the Care Companion program comes in, where you have systematic counseling that takes place for the mothers who are admitted in the, wards. I think Noora Health is piloting that along with UNICEF. So there are a lot of players who are into the gamut, and I think we should bring all of those players together. One last point is about the CLMUs or the lactation management units, or what you were talking about in JIPMER, the banks. Now, I think there is what you said, sir, is very critical. How do we look at connecting all the milk banks together so that there is exchange of learning? I know Telangana has come up with a lot of, comprehensive lactation management units, but I think it would be great if there is that kind of collaboration that could be established to take things forward. I think I will end here with the fact that, we had celebrity engagement when we launched MA in Government of India. I remember we had Madhuri Dixit coming, and there was a lot of hue and cry around the fact that she had joined the launch, but it never really percolated beyond a point. So, but if you look at internationally, how we have a lot of local MPs, MLAs, local parliament members who are really coming together and coming forward to share their breastfeeding experiences. I think that's one path that we can take as a community to involve the celebrities and to involve the MPs and MLAs and the Panchayati Raj representatives. So thank you, and that brings an end to it.
Thanks, Dr. Sarina, for adding that valuable insights. Otherwise, you would have missed to hear the good practices that's happening in different states and nationally. So I'll end with one last question to our delighted person sitting in front of us. As a father, as a parent, how did he care for the community? Let me translate in Telugu for him. Thanks అండి, మీరు ఇంత దూరం మా కోసము టైం తీసుకొని వచ్చినందుకు. మీ పేరు, మీరు ఎక్కడి నుంచి వచ్చారు, ఇంట్రొడ్యూస్ చేసుకోండి.
ఇక్కడ సికింద్రాబాద్ లో మాట్లాడుకుంటాను. మీరు పిలిచినందుకు మీరు మమ్మల్ని గౌరవించాలని చెప్పేసి వచ్చేసాము.
మీ పేరు ఏమన్నారు?
రాంబాబు.
రాంబాబు గారు. ఓకే. సో ఇంతకు ముందు మనం చూసిన మదర్ చైల్డ్ ని కేర్ తీసుకోవడానికి బయటికి వెళ్ళారు. ఫాదర్ మనందరు ఇక్కడ కనిపిస్తున్నారు. మేము విన్నాము మీ వైఫ్ దగ్గర నుంచి మీరు చాలా సపోర్ట్ చేస్తారు అని, బ్రెస్ట్ ఫీడింగ్ తను తీసుకునేలాగా మీరు ఎటువంటి సపోర్ట్ చేశారు? మీకు ఎందుకు అనిపించింది తల్లి పాలు చాలా ఇంపార్టెంట్ అని? ఎక్కడ విన్నారు మీరు దీని గురించి? కొంచెం మీ ఎక్స్పీరియన్స్ షేర్ చేస్తారా మాకు?
లేదు మేడం, అంటే మనం ఈ వయసులో ఉన్నాం, మన పెద్దవాళ్ళు కూడా మనకు చెప్తుంటారు కదా, ఎందుకంటే వాళ్ళు ఎక్స్ప్రెషన్స్ పర్సన్స్ ఉంటారు కదా, మనకు చెప్తారు కదా, అన్నిటికంటే చాలా గొప్పది తల్లిపాలు, అన్నిటికంటే శక్తివంతమైనది తల్లిపాలు. ఎన్ని ఫుడ్స్ పెట్టినా, ఎన్ని బేబీ నుంచి తెచ్చిపెట్టినా కూడా అది అంత శక్తివంతమైన చెప్తుంటారు కదా. అలానే మా పేరెంట్స్ కూడా మాకు చెప్తుంటారు కాబట్టి దాన్ని నేను ఫాలో అయ్యాను. తనకు కావాల్సింది ఏదంటే సపోర్ట్ అడిగింది అలా తెచ్చి ఇవ్వడం, తను ఏమడుగుతుంది ఇవ్వడం, పిల్లలు కానీ తనకి అలాగే.
మీరు పని కోసం బయటికి వెళ్ళిపోతారు కదండి, మరి మీరు ఎలా ఎన్షూర్ చేశారు మీ వైఫ్ తల్లిపాలు ఇస్తున్నది ఇంటి దగ్గర?
ఓకే మేడం, నేను డైలీ వెళ్ళేవాడిని. ఇప్పుడు ఏంటంటే నేను మామూలుగా డెలివరీ అయిన తర్వాత తగ్గించాను. తను వాళ్ళ చుట్టూ ఉండడం, వాళ్ళని చూసుకోవడం, తనని అడిగింది ఇవ్వడం, అలానే ఇక్కడ ఇంట్లోనే ఉన్నాం కొద్ది రోజుల వరకు ఇప్పటి వరకు.
మీకు ఏమైనా ఛాలెంజెస్ ఎదురైనాయా మీ ఇంట్లో వాళ్ళ దగ్గర నుంచి కానీ, లేదా సొసైటీ నుంచి కానీ? ఒట్టినే తల్లిపాలు ఇస్తున్నారు, బిడ్డకి శక్తి తగ్గిపోతుంది, మీరు అదర్ ఫుడ్స్ యాడ్ చేయాలి, ఇలాంటి ప్రశ్నలు ఏమన్నా మీరు ఎదుర్కోవాల్సి వచ్చిందా?
లేదు మేడం, అలాంటిది మనం అంగన్వాడీ మేడం గారు కూడా మాకు బాగా సపోర్ట్ చేశారు. అన్ని పెట్టేయాలి, మీకు తెలిసింది పెట్టేయాలి, మేము కూడా చెప్తామని కొన్ని మేడం వాళ్ళు కూడా చెప్పారు. దాంతో అలానే ఫాలో అయ్యాను, అంతే మేడం.
థ్యాంక్స్ అండి, ధన్యవాదాలు మీరు వచ్చినందుకు. I think it's a very good ending to hear that a collective support from the father from the parents, from the grandparents, and mother herself has been educated that the importance of the exclusive breastfeeding and the organization of breastfeeding. And also there is a support from the Anganwadi teachers and the hospital they visited. So it's a kind of, we are witnessing a good practice, how it can turn around if everyone does their job properly. I think it's a good end to do with. I will hand over to Dr. Murli Garu to close the session. And thank you once again for all the panelists to be here.
Thank you. We had a very interesting and interactive session. Dr. Prashanti has done a wonderful job by honorary doctor given to her by NIM. So at least she, with the end of each panel, this opinion, she was briefed of what highlighted opinions expressed by.
Practice IBCF, I've been trained in the IBCF.
So, yeah.
There's a community. So that means I'm knowledge about why it is important, but I'm not enough.
But it doesn't matter because with that, I just want to. Any questions we have? Anybody want to have any questions?
Questions from the online, I which will just.
Yeah. So for the online analyst. Online.
Okay, one question I can see is baby born of C-section, mother is given anesthesia. Will that have any impact on early initiation of breastfeeding? Can any of the panelists take it?
Yeah, Madam.
Not really. So coming to the anesthesia for cesarean section, majority of the cases are done under regional, that is spinal or epidural. So that means that the mother is anesthetized waist down, but she's awake. She can hear her baby, see her baby, and feed her baby even on the operation table. So that anesthesia effect would not interfere with breastfeeding. It's about having the protocol, having the policy, and putting it in place and auditing it. That is done. Would you like to add?
Yes, for this, yes, what you said was right. But exactly what they meant is to ask, like, whether is it possible? Yes, with the companion or the person who is attending, it is possible. It is not the ideal position to keep. How to keep the baby in position to breastfeed at that point when abdomen is being monitored or when managed by the obstetricians on both sides. So when you have the breast and the baby lying, there are different positions at which you can place the baby, right from head down. Like the head will be on the breast and the body will be well supported by the person who is holding on. So there are techniques by which you can use. You need not express or you need not roll down or you need not ask the mother to turn. It is the person who is companion. That's what we are saying, like get them trained. Let it be the person who is from the family itself or whoever is attending to the delivery. So we have the policies, we have the things, written policies, documents and all. Yes, they lie in place. But coming to the practical point of view, when you stand there, when you show the baby's face and once the baby is placed onto the mother's breast, that feel what the mother feels or when she holds the baby, that stimulation is totally a different feeling. So let it happen. Once it starts happening, all these things can fall in place.
Thank you. That's a very good answer. Yes.
Here I want to add one point. Even the government has appointed lactational workers, especially to the OTs and the labor rooms, to initiate breastfeeding immediately after the section is over. When the patient is out, they are starting the breastfeeding. In the labor room, automatically after the delivery of the baby, the lactation workers used to feed. So they are very helpful and they are only concerned only for the lactation. That is the government has adopted for that.
You also have breastfeeding stamps that have been actually.
Yeah, we have the breastfeeding stamp. When the baby was delivered, when the breastfeeding was started, who has started, even the green stamp, blue stamp, and red stamp when the baby was not fed is also there. So green stamp within months.
Yeah, green stamp is what madam is mentioning, like the first 1 hour initiation is green stamps. Once after going to the postnatal ward, if they start, it is a blue stamp. And if they didn't initiate in the 1 hour or even if going to the postnatal next 1 day also, then it goes to the red. So if we get more number of reds, we have to sit back and we have to look at what were the faults or why it didn't happen. So that brings us to the.
So this red stamp usually we see when the baby was shifted to the FMCs and all. When it is very preterm and all, we have the red stamp. And very few are blue stamps and most of them are green.
Point is, it can be done.
Yeah, it can be done. Even the smell of amniotic fluid and the breast milk is same. So as soon as the baby is born, if we can use the breast crawl technique, so that the baby is put to breast immediately. We have beautiful breast crawl videos online, so they can.
And maybe there is need for some policy guidance on this, specific policy guidance on post C-section.
I think there are no more questions. It's all messages largely. Thanks.
I want to share our experience in Gandhi way back now when this lactation council is not appointed. We had about 4 10th class paid people who were given along with SNCU staff. We trained them in just breastfeeding, and their job is to just see that babies put to breast soon after delivery. And our we had a PG thesis also on that. The early initiation of breastfeeding, which was just less than 10%, has gone up to 67%. Just the work of them is to see that the baby is put to breast soon after delivery, whether it is a normal delivery or C-section. So like that, so that sort of somebody behind that, somebody's job is just to do that only, because others are busy with their own professional work. So that was a very good experience with us. So I think we had a very good interaction, and we had a very good fruitful discussions. And mainly the early initiation is lacking now. The statistics are not improving, and we all should do something for that. Thank you. Thank you very much.
Ladies first and ladies first.
I think the number is less for the men, so I expect the men to be part of this important discussion.
Now we have to go to check. I also request Dr. AD to come on to the dais.
One photograph.
Yes. First, we have one speaker. We have 3 speakers to be honored, sir. First, so it's been reversed. I request Dr. Adishishan Garu to please come on to the dais. It's an enlightening talk given by Adishishan in the morning session, and has set the tone for the rest of the consultation. So,
Maybe if you could join the first, we can take a picture.
I request Dr. Sir. I also request the chair to give a memento to Dr. Antaryami Das. We also had 2 quiz participant winners. We also had 2 quiz participant winners. I think one is already a panelist. And photo?
Yes.
Okay. Yeah.
Yes. Who did not get to
You also speak.
I already got that.
Just a minute. One more, sir. Thank you.
Yeah, so we have 2 participant winners. First is Dr. Maimuna for the first prize. In 8 questions that was done by Dr. Antaryami Das and 9 teams. So we have the first prize winner. First prize goes to Dr. Maimuna. She has got 2 cups. She has got 2 cups now. Which color? 2 colors on it. I think it should not be the same color. Orange, both are orange. You can take one more color.
Yes, blue.
One for office, one for home. O for orange, one for one for home and one for office. And we also have what is full name? VA is Vasanthi. Please come on to the dais. So she is under participant second prize. We request. So. I also request the couple who has come on for the panel discussion. On behalf of the couple, I request the father to come on to the dais and receive memento.
Maybe if mother is around, they should call the mother.
I think the mother is outside. I think so. I think one on behalf of the mother, I think the father is taking. So it's a cup. So okay, let us give one more cup to the father. So it's good. So I think on one more for mother. And we have two Anganwadi teachers who have come and two Anganwadi teachers who have come for the panel discussion. Please come on to the dais. Yes, I call. Yeah. I request Dr. Rupali to come onto the dais, who has been comparing the entire session in the afternoon. Please come onto the dais, Rupali. Yes, please. I'm sorry. Okay, anyhow, we're a little confused. So it's okay. I think we're giving honorary doctorates now. So yeah.
We all become doctors.
Yeah, so great, Rupali. Yeah. I see it. Done. So mother and baby we all had. So mother was given. Yeah, mother and mother. So which side? All right, I think wasn't. Yeah. So I think. Yeah, so with this.
Okay. Sir. Okay.
I request Dr. Tina to do the formal vote of thanks, after which we'll have lunch. The lunch is at the guest house. So we'll show you the way. So after Dr. Tina finishes.
Thank you, sir. Good afternoon, one and all. It's my pleasure to propose a vote of thanks on behalf of the organizing committee. I would not take much time, as we know we are all running late. I would like to express my sincere gratitude to our guest speaker, Dr. Adishivam. Sir has enlightened us with his expert knowledge and practical tips on breastfeeding. And thank you, sir, for sharing your valuable insights with us. And I would also like to thank our speakers, Dr. Antaryami Das from the Save the Children and Dr. Rajesh Rishwan from NIN for sharing the details on the evidence and gaps in breastfeeding. I would also like to thank our chair, Murli sir, along with the moderator, and then our distinguished panel members, who have shared their experiences. And we all know that the celebrations would not have been possible if not for the support, encouragement, and guidance by our director, Dr. Hemlata. And we thank Madam for all her guidance and support. And I would not forget to thank our conveners and staff of all our departments, the maintenance, electrical, IT, and transport committee who worked to make it a success. And I would also like to thank all our participants, both offline and online. We had a great response from the online participants and who have made this event lively and interactive with their presence and involvement. And no doubt that this event had been a wonderful opportunity for all to learn more and motivate each other, and also take these valuable learnings back to our households and our community as well. And I hope you all like this as much as we liked this event ourselves. And thank you very much.
This one. Can take the guest. You share.